It's to send link to Greg.
You're breaking up.
Somebody needs to send the link to Greg, please.
Send the link to Greg,
Please.
the Zuho, or Lindsay.
Yeah, Lindsay can take that on. And Patty, you're coming in pretty choppy on our end. If you have a minute to hop off and hop back on, sometimes that helps, but it's hard to hear you right now.
Okay, we've got 1, 2, 3, 4, 5. We technically have 5. We could start the meeting, but let's wait for 2 more minutes. Okay. I see Kara. I saw Kara for 1 heartbeat. There she is. Okay, Kurt, good to see you with that beautiful background of our gorgeous colors. Greg, good to see you.
Made it. Thank you.
Karen, do we have quorum yet? I think we do.
Actually, I don't know if we do. We have Greg and Tori and Brent as voting members. That might be it right now.
And
Okay.
Marky, so that should be 4.
Oh,
Pardon?
Marky. Yeah, sorry, Marky. I forgot about you. Yes, Marky,
Well,
you're 4.
I'm only 34 days away in 2 hours. And who's counting?
Wow.
And then we'll have to figure out what my role is going to be, or if there will be a role with the Board of Health. So that's an offline conversation. Let's go ahead and get started and call the meeting to order. And we do have quorum, so I do want to thank everyone for spending part of this gorgeous day really focused on a very pressing issue, which continues to be COVID-19. With that said, I'm going to see if I have a motion for approval of the minutes.
Move to approve.
Thank you. Do I have a second?
Second.
Thank you, Brent.
I'll second. I appreciate the second there. I just wanted to say once again that the minutes here are, they don't track any of the language or flow of the meeting. And I brought this up in the beginning. I just was wondering, did Karen, did you say that that actual meeting minutes should be, these are recorded so that they're available?
Yeah, Tori. So we really try to keep the minutes to decision making and approvals of those decisions. All the board meetings are recorded. We do take more kind of detailed they like translate or transcribe the recording, and that gets put out. So that's something we could maybe link back to with the Board of Health and just give you access to that. It gets posted on a social media account and that kind of thing.
Oh, neat.
So
Okay,
actually,
thank you.
yeah.
Yeah, just wondering if the actual conversations are captured.
They are.
Thank you.
Okay, with the motion and the second, could you please raise your right hand for approval? Okay, you have approval of the minutes. We will be adding 1 extra item today, and I will go towards the end of the agenda, and we're going to talk about testing. I know that we're being, I wouldn't say inundated, but we've received quite a few emails associated with this topic, as well as some news media as well. So we will be tackling that, and I know David Ressler will be joining us for that part of the conversation as well. So with that said, let's move right into the director's report, because we got a busy agenda.
Yeah, thanks,
Okay.
Marky. And I did want to add I wanted to give 2 updates that didn't make it on the director's report, but I think are important for the board to be aware of. So if that's okay, if I can add those two as well.
Okay,
So I'm going to go ahead and start with the first. I wanted the board to be aware that we finished the hearing with Scarlett's today. And just to give you kind of a big overview of that scenario or that situation and kind of where next steps we're moving towards. So just for your situational awareness, on September 4th, 2020, Scarlett's had violated the public health order. The components in that violation included patrons and employees not wearing face coverings, including the owner manager, that permitted patrons, Scarlett's permitted patrons to cluster together in groups of larger than 8 at both tables and also in common spaces, that there were more than 8 people in common spaces, and a failure to maintain that 6-foot social distancing requirement. That Scarlett's failed to limit the maximum capacity to that permitted by the public health order and failed to have adequate staff to control over the number of individuals present in the business. So upon those public health violations, we issued a notice of violation and closed the business on September 6th, I believe. So I wanted you to be aware. So our process is to have a hearing. The public health director, myself, served as the hearing officer today. And we worked through an arrangement in which there was a revised business safety plan that the establishment presented, which is more rigorous than our business safety plan that we have every business fill out. So there were additional components within that business safety plan that Scarlett's presented. Those included security, extra security inside and outside of the location and street level to ensure that safety protocols are in place, that they would work with and perhaps even hire local law enforcement as a support system for implementation of safety protocols, that they would have security ensuring that all guests adhere to proper mask usage when not seated at a table, and security will ensure all employees wear masks at all times. And then they would rope off the tables so that it was really clear to patrons, where to be and not to kind of mingle between tables. And then also to put up a partition install to help with social distancing. So we talked through that. We added a couple additional factors to that site safety plan, which included if an employee has COVID-19 or is a close contact to someone with COVID-19, they would follow public health instructions and isolate and quarantine orders, and they would cooperate with case investigation and contact tracing. We also included some language around really adhering to the state restaurant guidance, and that is the guidance that the establishment would need to be following and to be able to stay up on top of changes in that guidance. We also included just some pieces around ultimately kind of the process for opening. So we added components to the site safety plan. And then the process for reopening is that Scarlett's will go ahead and get all of these things in place. We will do a site visit with the compliance program with both Pitkin County and the city of Aspen, and that site visit would happen on the 5th. And after that site visit, if all of the safety measures and safety plan is adhered to, that the establishment could open after that site visit. We agreed that there would be weekly site visits during the first month of operation, and that we would continue to communicate about education if there were further loosenings or tightenings of a public health order, the state public health order. So I just wanted you to be aware of that. And we haven't signed any documents yet, but this is the direction that we're going. And so I wanted to bring your attention and keep you updated on that process. So I'm available for questions on that.
I have a question. Yes, Brent. Karen, how much were they fined initially? And then how much were they fined secondarily?
Yeah, so there's been no fine issued.
From my perspective, you know, and I'm here in Aspen, and I heard about this as it went on, and, you know, we all shook our heads and couldn't even believe it. Tell me the rationale. I mean, if I were king, I would have a substantial but arguably reasonable fine for the first offense, and I would have a punishing fine on the second offense for egregious disregards of public orders, because people's lives are at stake here. So just tell me, does some entity, or do we have that ability to impose fines? And if not, why do we not? Why don't we make this an example? And I like Scarlett's as well as anything, and I certainly want to see them in business, because Over Easy got brought into this in sort of a secondary and sad way. But you know, what's wrong with having a strong fine schedule that people then see and go, boy, do I not want that to happen to me? Even if they think they can fight it in court, it doesn't look good and it hurts. Anyway, my thoughts.
Yeah, so to your first question, Brent, we have the ability, if anyone violates the public health order, to leverage the language reads, failure to comply with this order is subject to the penalties contained in section 25(1)(516) and 18(1.3)(501) Colorado revised statutes, including the fine of up to $5,000 and imprisonment in the county jail for up to 18 months. That's always our ability to leverage that enforcement. We believe that closure of a business for 30 days has a pretty significant impact on that business, and has probably the equal punitive effect.
Now, in my view, I think you may be right, and I'm not arguing against that, but when you close a business, you're closing, you know, we all know this, we're closing livelihoods and well-meaning people that put their heart and soul and money into these things, and then all of a sudden, you know, they're out of business. My feeling is that, you know, it all begins at the top, and that if the owner or whoever was, especially the person that was on site that had an interest in the operation, I personally am in favor of a personal fine, and this probably goes, you know, is counterdictive, but the idea of trying to keep these places in business and penalizing the people that are really at fault and in control, that to me is a better way of looking at it. But I know that may not be traditional, and I'm not saying I'm right. I'm just saying that's just from my perspective.
And Brent, if I could just add in, sure. It is not our decision as to exactly what that fine or jail time would be. That would have to go through a judicial process, and that judicial process is also especially time consuming on staff and resources.
Yeah, I understand.
And so, and also takes just a great deal of time to bring to conclusion. We have always listed our goal as compliance versus punishment. That's been our philosophy, and it's a legitimate conversation for this board to have. And so we take progressively more stringent steps towards compliance before pursuing those types of criminal charges, which can be difficult to go through. So I just add that additional context.
Sure.
Any other questions? Let's move on. Karen? Tom?
I'd like to comment. I think this was not the first time liquor-wise this establishment was having a problem. And it was not a question so much of the guests, but the manager and the employees were not wearing masks. So I think when you do the audit, be sure that the manager and the employees are wearing their masks.
Mm-hmm. Okay, thank you, Tom. Let's move on. Karen, anything? You've had 2 items. Any other?
Yeah, and now the other one's eluded me, so I'll get back to that.
Let's move on then to Josh and his report.
So Marky, I am going to flip the order here. I'm going to start with the director's report, and we're going to dive into the chronometer and the dial. And
okay.
We're going to put the data in Josh's report to align with the hospital data and the testing conversation to just kind of bundle that together at the end.
Sounds good.
Great. So as you all recall, in the last Board of Health meeting, we talked about how the state had come out with a new dial, which is actually modeled after our Coronameter dial. And through that process, they launched that about 2 weeks ago. And we have been evaluating their data, really looking at a cross section of the 3 indicators that they have on their dial, and been looking at our data, and have had a lot of robust conversations within the department and with stakeholders and partners to really think about what does it mean to move from the local into the state system. And so we brought this to you last Board of Health and said we would come back to you with some thoughts and recommendations after we did some analysis on this. So I'm going to lead you through a process through this PowerPoint in which there will be some decision making for you all to do. We're actually going to ask you to make 4 decisions as we go through this process. The first decision will be based on the metrics. And I just wanted to get everybody on the same level playing field. When I say metrics, I'm really talking about the COVID-19 data used for decision making. And the decision making is really around the measures. So as the metrics, as we've been doing for a long time, looking at metrics and thinking about, well, what does that mean for capacity and how do we move through our roadmap for reopening? That's really the system that the state has now set up. So it's not different than what you all are familiar with and what we've been doing for a long time in Pickens County. But now we're talking about, again, looking at the state system as opposed to how we've been doing it in our local community for a number of months. So the measures, when I say measures, I'm talking about social distancing and transmission reduction. You might think of these as things like capacity or mask wearing. So these are measures that are put in place that align with the metrics, so the numbers that we're using to look at around case counts or incidence rates or positivity rates or hospitalizations. And then public health order. The purpose of a public health order is to enforce measures. So we really want the public health order to be a tool that aligns with the measures, and then is in essence, what we just talked about. It's the enforcement tool to ensure that those measures are being met through the community. And then finally, the movement of the state dial. We want to talk to you about the process of how to move through the state dial, what that looks like, in the Board of Health's role in determining kind of the pacing of the movement within that role. So I'll stop there and see if you have any questions before we dive into those four things. Okay. All right, so next slide, please. So again, we just wanted to situate you to the state dial. Some of you may have had a chance to look at it, but we wanted to just do a kind of an overview on this. And I don't know who on the team is going to take this slide, if it's me or I think someone else is taking it. And if not, I will. Okay, no one's piping up. So
Tiffany's available for details, and we thought you were going to explain it.
okay, I'll do the high level, and then Tiffany can answer all the detailed questions that I won't know the answer to. So right now, I just want to, again, situate you. So the state dial is at the very top of the slide. You can see that there are 3 different levels of the safer at home. There's level 1, there's level 2, the yellow, and level 3, the orange. There is stay at home in the red, and then there's protect our neighbors in the green. And what we're talking about here is really focusing in on the safer at home components. Once you're in stay at home, that's kind of its own category. And protect our neighbors has different metrics than the metrics that we're looking at here. These are some of the metrics of protect our neighbor, but there are additional metrics to get into the protect our neighbor phase. So that's a little bit of a unique part of the dial, the green color. So when we look at right now, just for your awareness, this was actually as of yesterday at the end of the day, we can see that Pickens County is, and these are the 3 metrics the state is using. So they're using a incidence rate, they're using a positivity rate, and they're using hospitalizations. So you can see that as of last night, our positivity rate was in the green zone, our hospitalization was in green, and then you can see that our cumulative incidence over 2 weeks, it was in yellow. So overarchingly, you have to meet all 3 standards in order to be able to move in the dial. So that leaves us right now at yellow. That's where we are. We're still in the concern phase. That's where we started 2 weeks ago. So we're still in the same level. As far as how the county moves between levels, we look at a 2-week period. The first day, again, to move to a new level was actually yesterday, but when we looked at the dial, we weren't eligible to move. So I'll just, any questions about that, just sort of overarching understanding of what the dial means and how it works.
Quick question.
Yeah.
If I could, this is Tori. Karen, you are referring to the level that we're in as level 2. But when I look at the dial, that looks to me to be level 3, because protect our neighbors, I think, would be level 1. And I mean, I guess I'm just talking a little bit about, I get, so it says here, safer at home 1, safer at home 2.
Right.
But anyway, I just wanted to point out that we're referring to a level 2 of an area of this dial. It's really level 3, because what we'd like to do is get to level 1, which is protect our neighbors.
Yes.
Okay.
Yes, you're absolutely right. So the way
right.
that's, and remember, the state designed this. So the way that they designed it was safer at home has 3 levels in it, and they start with 1. So we really say safer at home level 1, safer at home level 2, safer at home level 3. But yes, ideally, and remember that protect our neighbors was first. So the state developed a protect our neighbors phase, and then they went ahead and flushed out the rest of the safer at home piece. They always had stay at home, and they then developed protect our neighbors. Then they created this 3-tiered system within safer at home. So you're absolutely right. We're in,
Okay.
overarchingly, we're in the 3rd level, but in safer at home, we're in level 2.
Thank you.
Yeah.
Karen?
Any other questions or points of clarification? Yeah, Jeannie.
Karen, I just wanted to ask if the incidence includes only residents, or if it also includes out of jurisdiction cases.
Yeah, great question. And Josh will talk a little bit, he'll dive into this data a little bit more deeply with you all, but the state is this is again, based on state data, and the state has always just looked at our residents. So it's only Pitkin County residents as our denominator for all of our numbers. So it doesn't consider out of jurisdiction. You know, our data considers what we've been looking at is like what's community spread at Eagle or what's community spread in Garfield, and none of that is captured. So it's truly just Pitkin County resident data. Any other questions about that? Okay, next slide. So I wanted to just paint the picture of what the team and our, you know, when we've reached out again to different members to think about, well, what are the advantages and disadvantages of what are the advantages of our own system and what are the advantages of the state system, and really just wanted to paint that for you, because these are the things that we considered when we are now going to bring you some recommendations that you'll make decisions on. So we do have recommendations for you. And what we really looked at was, you know, no matter what, we always know that the state is baseline. So we have to, you know, the state data, those 3 metrics are definitely metrics that we will be looking at. And the measures, the dial are baseline. So whatever that says, we have to do. We can always make things, as you know, more strict or tighten up. We can always have more ways to increase social distancing or reduce, you know, transmission of disease. So we can have that ability to expand, but we always have to have that baseline with the state. We recognize that since almost every single county is now on the state dial, I think Gunnison may be the only county that's going to retain their own metrics and move through their own chronometer, that there is consistency then across the region. So if an entity wants to compare our data with Garfield and Eagle's data, they can see apples to apples comparison. And so we think that that's an advantage for the community. We did, again, hear from stakeholders and sector groups that the state dial is more clear. It's easier to just understand the metrics, and it's easier to understand how those metrics are impacting how those metrics are impacting measures. So the metrics tie directly with the measures. So you can see that there's capacity limits based on the colors, and that the community liked that clarity, and they liked the, just the simplicity of it, I would say. It allows us, if we go to the state dial, to really look at our role in community a little differently. So we've been, because this didn't exist, and we had, again, our chronometer before the state, we had a roadmap to reopening before the state. We had a lot of things in place, and we built up a really robust data system and metrics that we really believe in. But we recognize that when we do all that work, it doesn't allow us as much time to be the face of education and support to the community. And so by going to the state dial, it kind of frees us up. We're not doing this thing, I think Jordana had mentioned, like this, we would create guidance because the state didn't have guidance on some topic. And then the state would come out and create guidance on that topic. And then the state would change the guidance on that topic. And we had to kind of go back and forth with our own guidance and update it. And it just was a lot of administrative work. By going to the state system and the state guidance and the state metrics, it allows our team to do more supports in helping our community to understand what that guidance means, walking kind of beside them and allowing more of a dialogue to happen and getting to compliance around the state order. And then again, this is maybe a negative. We are finding a lot of data discrepancies between how the state collects data. And Jeannie, what you just said kind of alludes to this. Like, we have tried to have more nuanced data in how we've collected it and analyzed it, and the state, and again, Josh will talk a little bit about this, just so you're aware that we will continue to monitor the state data, because I think there's some work to do around how the data is being displayed from the state level. And then again, we've had more robust metrics that have just given us a clearer understanding of what's happening in our community. So questions about what we've considered as we go through our recommendations for you all?
I'm going to have a few questions about the metrics, and here it's listed as number 5, metric and data discrepancies. Is it possible to go back one slide?
Sure.
Thank you. So Karen, I guess, some of the issue that I've been having with this, and both before we were talking about possibly adopting the state dial or not, but one of the things that I question is the validity of the thresholds that are set. The incident rate, the positivity rate, I think is at a 5.0 is kind of and I've really just wondered about how those not are chosen, but how they are applicable in different settings. So an incident rate that is going on in Denver or Boulder, I would think would be a different cause of concern than it might be in a more rural area, whether better or worse, hard to say or whatever. But I'm just saying, like, I do have questions about the validity of the thresholds. And then as those relate to the measures of regulation. So I'll give you a quick example is that, like, if your positivity rate is one thing, but you're not seeing those transmissions in a certain business segment or a certain community segment, it just doesn't, the regulations that can be kicked in for the different levels don't seem directly related to the struggle that individual areas are having. Does that make sense?
Yeah. Yeah, it absolutely does. And Josh will, I'm thinking, address your first question, but if we don't get to it, we'll circle back to it. And I think, Tori, that was kind of, for a time with the Board of Health, we talked about that scalpel-like, adjustment. So if we saw, group sizes, we're just seeing a lot of disease transmission because people are gathering in big groups, and there's a lot of informal, informal things going on that are increasing transmission, that we would kind of target that, right? And say, okay, that's where we're going to have the scalpel-like thing. We're going to reduce group size, which actually we did do one time. And so I think I get, you know, I think that's what you're saying. And that is the advantage of having a more localized response, because we can look and sort of have that taken. It's not just this blanket kind of, okay, the whole sector has to go to 25% or something, right?
And
Yeah.
can I add on to that though? Because Tori, I think one of the things that the Board of Health needs to be considering is that the state is using this meter and the mitigation measures associated with it, regardless of whether we use our own. And so while we can be more restrictive, we certainly can't be less restrictive by sector, depending on where we're at in the state's coronameter. So that's regardless. That's how it's working. So I just want to be sure we have that policy versus data perspective.
Yeah. Well, and John, that's, I mean, you're kind of hitting the nail on the head for kind of what I'm saying is that, you know, we're getting these dictums from the state level. And I totally understand what you're saying, that those levels are set at where they are. And that's where it's difficult for me. That's where I'm just, you know, for me, the state, in the variety of communities that exist across the state, I think it's just very hard for that scalpel, like that really precise kind of targeting for really attacking where your transmissions are happening. So I guess part of what I'm saying is, I don't know if there's opportunity to have that larger conversation with state leaders and such, but you know, there just doesn't seem to be the direct correlations between some of the data numbers that are given and what's going on the ground. And I know this is a longer conversation, but you just hit it on the head, John, is exactly that. My questions are really about the validity of those thresholds. It's not whether we are using them or they're using them. I understand we're under that guidance, but I question them on a state level. That's all.
Could I say something just quickly to this, if I can? Yeah, just to Tori's point and also to yours, Karen, about it being local and Tori talking about kind of the statistics. I just saw this earlier this morning and I think it's rather insightful. And that is, if Jeff Bezos walks into a bar of 100 people, I've got a fire alarm going up. The average wealth of those 100 is now 100 million. So you got to be careful of statistics. And I believe there's this Tom Kirk would know about this and probably Kim, but there's this thing called decay factor, right? Which says that small portions can have a disproportionate effect on the whole. So when we look at these big statistics and we dial up our awareness, I mean, that is meaningful in a universal sense, but it really comes down to perhaps more local, as Karen was saying, a more local response and a more pinpointed response, because we're more aware of what's happening specifically than, again, the general picture, the forest for the trees kind of an argument. Anyway, that's my thought.
Okay, Karen, you want to proceed?
Okay, so again, we're going to walk you through each of these decision points. So where there's a number, we're going to have you make a decision, but I'm going to start with the metrics. So next slide. And just as an overview, again, this is just a snip, so it's not the full, actually, no, this is the full one from the state page. So you can see again, as Tori said, there's actually 5 levels, but we're not talking about protect our neighbor right now anyway, because that's a little bit more of a detailed conversation, but you can see the incident rates. So the thresholds that Tori was referring to are right there. You can also see the percent positivity, and you can see are there stable or declining hospitalizations. And then also the nuance in ours is that it's, I think, two hospitalizations a day. So it's either or, kind of questioning on that. So these are the metrics that are associated with each color. And then again, it's a two week churn on this. So Just wanted you to be aware of those metrics as Josh goes in, because what he's going to do is do a comparison of our metrics and the state metrics. So Josh, can I turn it over to you?
Yeah, can you hear me okay?
Yes.
Okay. Tori, did you have something to say before I jump into it?
I was hoping maybe in that first line of metrics, the case numbers, where it is 0 to 75 per 100,000. Can you use numbers that are relevant to our populace here in those areas? So what are we 0 to what per? We're at 18,000 for Pitkin County. That's what I'm saying.
Yeah, it's about, for safer level 1, that'd be about 14 cases over a 2-week period. So that'd be about 1 case per day to be under 75 per 100,000.
Thank you.
Sure. Okay. Good afternoon. So as Karen mentioned, I just want to show you what the comparison of our data looks like. So we took the data that we have here and that we collect in Pitkin County and are comparing it with what the state is using to inform the state dial. So the first slide here is looking at the positivity rate comparison. So the blue line is showing our Pitkin County positivity rate since August 26th through, I believe, the 22nd of September. And so you'll notice that, we've peaked up into that red area. And so the two colors here, red means that we'd be in safer at home. And then green would be, we're more falling into that protect our neighbor phase. Not to say that we would meet protect our neighbor, but we're falling into that threshold where we want to be, that safer level 1 or protect our neighbor type threshold. So you'll notice that with the blue, we hop and peak up into the red a little bit, and then we move back down. When we look at the state's data, which is what's there in orange, you'll notice that there are some differences in what they are finding and what they're reporting out as the positivity rate and what we're finding. And it actually goes back and forth. So at certain times, our positivity rate will be higher, and what the state is reporting for us will be lower. And then it actually has flopped or flip-flopped more recently. So now we're seeing the positivity rate based on the state's data show up a little bit higher, closer to 6%, whereas ours is down near 3%. So we are seeing a pretty significant difference there at times. There are times where the data is pretty closely aligned, but we are seeing some discrepancies there in the positivity rate. So as the state is reporting that positivity rate, with the report that we have, we may see discrepancies there as we move forward. And this mainly has to do with how CDPHE gets their lab results and how we get our lab results. So there's a difference there in the test that we're looking at and the test that we're using to inform the positivity rate. So if you look at the bars in the background, the blue are the total number of tests that we've reported out of Pitkin County, whereas orange are the total numbers that the state is reporting for us. So you'll notice that at any given day, we have about twice as many tests that we're reporting in our local data than for what CDPHE is using to inform their state dial to calculate the positivity rate. So that's positivity rate. That's the difference there. Next slide is incidence rate. So again, there's a difference in how we report incidence rates and how the state is calculating it. So blue is using our Pitkin data and orange is using CDPHE data. Again, red is, would put us in the safer at home, and then green would be more in that protect our neighbor type area. So you'll notice that they trend together pretty well if you look at it at a glance and from a 10,000 foot view. But when you hone in a little bit more closely, there are some areas or some days in which the data does differ somewhat significantly. For the most part, they're pretty well correlated. So there's not a huge difference here. One of the differences that we've noted is that at times CDPHE may be assigning out of jurisdiction cases to us. And so that will count against us. And then we will then later go into the state database and we will change that case and we will actually assign it to a different jurisdiction. And so that will lower our incidence rate here. So we've seen that happen a few times. More recently, the data has been pretty closely aligned. And so we've seen the incidence rate for the two systems pretty closely aligned there. But as you can see, there have been areas in which there are discrepancies there. Next slide. So now this is looking at testing capacity. So one of the protect our neighbor metrics, again, Karen had mentioned that, it's a larger discussion. I just wanted to point it out real quick. So this is, the state wants us to have a testing capacity where we can test 15 people for every 10,000 persons in our population. So it's about 27 people per day that we need to be testing. And so again, if you remember back to 2 slides ago where I was showing you the total number of tests that were reported, you'll notice that the state has us reporting significantly fewer tests than we're actually doing. Whereas the blue is the number of tests that we're actually doing. So here there is a big difference. The state never has us reaching that threshold of total number of tests that we would need to meet the metric that they are asking us to meet, whereas our local data is showing that we are. I will say that part of the testing piece is trying to integrate some of our, or not our, but some of our counties' databases with CDPHE, and that's in the works right now. And so once that is completed over the next few months, the data should more closely align when it comes to total number of tests reported. But until that integration is completed, we will continue to see that difference in total number of tests being reported using our data and CDPHE data. Next slide. And then a few other things just to mention is that, we also have a few other metrics that we track pretty closely here in the county that we find important when trying to think about, how we need to move and how we need to guide our community. And so that first one is community spread. And again, community spread is the percentage of people that do not have a known exposure. And so we've actually seen community spread decrease quite significantly in our county, which means that we are connecting cases back to a source. We're finding out exactly where they were infected. We have very few right now that we have not identified a source for. And I will say that counties around us, they are still struggling with community spread. They have seen that increase up to 60% in some counties. So they have a lot of individuals that are being exposed somewhere that they can't identify. So the fact that we're able to bring that down is significant. But that's something that is just, unfortunately not able to be captured by CDPHE data, just because it's a very nuanced type of data piece. And there's no way that the state would be able to track that, but we find that piece is important for us to monitor. Next slide. Okay, and that was it.
Any questions for Josh? Okay. Karen?
All right, next slide, please. So this is what we want to propose to you all is that we do use, as John said, this is the state data is baseline. The state dial is where we have to be. So, that's that's the starting off point. We would like to continue to show the community additional measures. So you can see kind of at the bottom of this sample page, this is what it could potentially look like on our website. But that we would continue to track some of these data pieces that Josh talked about, where we just feel like there's an importance of collecting this data and sharing it with the community and having this data really help us to understand more of a true picture of what's happening in our community. So looking at the additional metrics you can see at the bottom, some of those are protect our neighbor metrics that we're collecting anyway, and that we want to be able to share with the community to say, hey, these are the metrics we all need to be looking at in order for us to move to protect our neighbors. So we want to have that frontward facing to the community in addition to the safer at home metrics, the 3 metrics that we've talked about. And then there's some additional pieces at the bottom that we would like to continue to share with the community, like that out of jurisdiction cases and test turnaround time. All of these are really, important for disease containment. And so our proposal to the board, and we can go to the next slide, is to again have the 3 metrics from the state on our website. that we would continue to monitor the Protect Our Neighbor metrics and show those to the community. And then also monitor those additional metrics that I alluded to about a jurisdiction cases, community spread, and test turnaround time. And that would help us, again, have a little bit more nuanced understanding of what's happening in our community, be able to share that data with the community so that we're letting them know where we are. And this data can be helpful in us really thinking about our movement within the state dial. So I'll get to that. But I guess the first part is, does that make sense that we would have these kinds of metrics on our website? And we can, if you can flip back to the last slide, just so you can sort of see a visual of it. Again, this is just a sample, but that we would be continuing to share those metrics with the community, knowing that the state is the baseline and that we would have these other metrics that we're monitoring and may help us inform some of our decision making as we move through the dial. And I'll talk through about how that could look later.
Any questions? I think this looks great, personally. Very informative, very clear. Other people?
Question?
Lori?
Thank you. So let me see if I'm understanding what Josh just shared with us. The way that we are measuring some of these metrics and the way the state are measuring some of these metrics are different. Is that correct?
Yes.
Yes.
So if we move to the state dial, we would be utilizing the state measurements.
Yes.
Whereas if we do not, we would utilize our measurements.
Yeah, so the state, if we move to the state, those three measures at the top, we would want to go ahead and continue to use how the state's calculating those data points, because that is, it's frontward facing anyway, right? It's shared information in the community. And that's what they're going to be basing our opportunities to move through the dial on. So they're only looking at those three metrics. They're going to say, hey, Pickens County, you're ready to go to move into orange, or you're ready to go to move into blue based on how we're calculating those numbers. So our goal, Tori, is, I think what Josh was alluding to, is that there's some systems alignment. These are with electronic lab records. It's not something we have control over in public health, but something that they're working toward to ensure that the data that the state's collecting is the most accurate data from our perspective. So we're still working on that component. But right now, yeah, the way that the data is sort of fleshing out between the two is a little bit different. And we just want the community to be aware of that. And that's something we're trying to kind of, it's hard because it's hard when the numbers don't exactly match up. And Josh, do you want to add anything to that? I see you just unmuted.
Yeah, I would just add that Tiffany Greenlee, one of our subject matter experts, has been working pretty closely with CDPHE to help them understand the differences between our two systems and the two data sets that we use to try to get them to align as closely as possible with the data that we have. So those conversations are happening, as I alluded to, with the electronic lab records. So that work is happening. It's just, they're not there yet to fully align our two systems.
Thank you. I guess I really was so hopeful to support this transition and hoping that this transition would make sense and give some clarity, maybe some simplicity, and being under kind of one dial and one guidance. But to be asked to endorse switching to a system that is not even returning the same measurements that we are, and I'm having a hard time supporting that when the presentation that I just heard was that we're not even communicating on the same basis right now. So I'd love to hear from other health board members about how they feel about this, but like I said, I was really hopeful to be very supportive of this, but after hearing this presentation, I've got more concern than I had before.
Well, I think one of the, for me, it seems to me that the only way that we're going to be able to come out of one of these levels is to apply to the state, but the state's going to use their numbers, not our numbers. And secondly, I'm hearing that Tiffany is working very hard with the state to try to get the numbers to align and identify where there's discrepancies and come to a problem-solving mode to get more and more into alignment. So I just think it's best to go along with the state to free up some of our staff time to do a lot more education and focus more on compliance. But I'll let others speak. Brent?
Well, my feeling actually is kind of like Tori's, and I'll put it to me in a more simplistic way. If we, first off, do we have the ability to collect data? And we do. Well, shouldn't our data reflect us? And to the extent that the state wants us to go along, or even if we feel it's a simpler way to handle the data by going along with the state, I would argue that simplicity is not a goal. This is a difficult time for everybody, and it seems to me that our data should reflect our unique situation. But I'd like to hear in some sort of very, if we come up with a simple argument, why would we go with the state, or why would we leave our own data? Because our own data is going to reflect our own experience, regardless of. And then to Marky's point, if we're tracking our own data and the state takes a contrary position, well, we're probably going to have to go along with the state. So it doesn't change what's going to happen. The state's going to call the issue unless we want to fight it, which I suspect would take even more time. Plus, it probably wouldn't be in our interest. So I'm not sure the advantage of this suggestion. Thanks.
Marky, can I add a couple things?
Yeah, Suzuho.
So I just wanted to build off of one thing that Marky said and then add a couple things. So in regards to, Tiffany and Larissa and Jordana have all been doing an amazing job keeping up with all of this. And we will continue advocating to the state to get better alignment of our data. So we just want the whole board to be aware of that, not just our county, but our neighboring counties, and CalFO and others across the state have been advocating to the state to try and get better alignment. So that will continue regardless of this decision, because we know the importance of that. So I just wanted to make that clear that that is definitely a goal of ours. And then in regards to this visual, the top 3 indicators are the indicators that will be pulled from the state data. And this is going to be publicly displayed on their website, regardless of our decision here. And the bottom 10 that you see under additional metrics will all be generated based on our local data. So we will still have local data for these additional indicators. It's just the top 3 that the state is going to display on their website anyways, we feel would result in less confusion among our community if there's alignment for that. And the needle placement between our website and the state's website.
So we're going to reflect the local data in the lower portion, and we're going to reflect the state data in the meter portion. Is that correct?
Correct.
So yeah, and then maybe I changed my mind here, because I thought it was one or the other, and I can see as long as we're doing that, I guess I feel a little differently, especially if the professionals believe that that's a better and more efficient way of handling the data.
Kim?
Yeah, I just wanted to make a remark, and it builds on Suzuho's remark as well, that to me, this looks like a decision of creating consistency. And it's a political type of decision where you're going to create consistency. We have a valley that geographically has 3 different counties. We need to all be aligned in the same way and align with the state. And I think at the same time, if we can also continue to examine our local data in the way that we are examining it, we know that our metrics have a little more of an accurate representation of what's happening locally, that will be important for us. But it really truly is not simply a decision of which metrics are more accurate. And we hope over time, as Marky remarked, that in faith that the 2 metrics will come together more. But this is, I think, more of a decision of consistency in messaging, consistency across counties and with the state and in alignment. And so that part of the decision, I think, needs to be taken into account.
Tom, you had your hand up.
Yes, the state is really the czar. The state is really the czar in reporting diseases. And I agree with Kim that the dual system of checking cases locally can be helpful, where we find cases that the state has had reported, and we need to track those down to find out why those weren't really reported to us. And eventually those will come together so that the numbers will be the same. But we need to be compliant with the state. And I was hoping that the variation that we were presenting to them recently would be an approved variation, but apparently that it's not. So I think pursuing a dual system and seeing how it teaches us what to do will be helpful.
Anyone else? I'm
Another
scrolling.
comment from me then, I would just say this, we're looking for consistency, and yet we're trying to agree with a system that is not consistent with the testing numbers that we've been getting out of our community. I don't feel comfortable. Why don't we get that work done first? Why don't we get that work done first? Why don't we get some parallel track here between even the numbers that we're going to be basing decision making off of, or regulations off of? Why don't we get that done? And then, I mean, we're not even talking about the same numbers. So you're right. Hey, I would love to move to the state, but right now what I'm being shown is that the people that I've been relying on here locally, we're throwing that out and saying that our numbers don't match. I'm just having a hard time with this, and I really want to support this. I really want to support a consistent message, but I have some reservations here. And unfortunately, this is not something that I'm going to confer or can confer with my entire council on. But my representation is, as far as I know, is that we would like to endorse and support a program that has consistency. I would think that we would try to get those numbers in a line before we sign over to this. And maybe I just need more information about why these numbers are out of alignment. And hear that from the state side as well. Is the state dogmatic about how they're achieving their data? Do they think that their metrics are right? Do we think our metrics are right? And if they're off, then I would say we should clear that up first.
I don't know if I can talk a little bit just about the testing discrepancy. So it does go down to, and Josh, correct me if I'm wrong, but for example, we do, ABH does a lot of microgen testing, the saliva testing, and those ELRs haven't been integrated into the state system. So that's why we see a lot more in our numbers and what ABH collects, right? So we have a lot of, that's a primary form of testing in our community. So we're doing a lot more testing than, again, the state sees, because they're not getting that data right now. And Josh, did I get that right?
Yeah, that's right. Yeah, there's just a few labs mainly that are not currently reporting their data, all of their data, to CDPHE. They're only reporting positives and not negatives. So once they can correct that and begin to report all negatives, that's when we're going to see that closer alignment. But I will say that the positivity rate, it is different, and I wanted to present it all just so you're aware. And I didn't want to try to hide that information at all. But I will say that the positivity rate, although it does fluctuate, I mean, it is still, it's still pretty close. I mean, yeah, it is different. But is it far enough off that it's going to impact our decisions or how we move forward? I don't think so at this point. I think that it's close enough that it wouldn't probably make that big of a difference, over the next month or two until the systems are integrated.
Marty, if I could jump in, Tori, there may be one other way that before a decision is made that your concerns can be addressed, and it's kind of through process. So the the levels don't automatically move. That is a decision we're going to propose that be a decision of the Board of Health, so that you all have an opportunity to review what's happening with the state data, as well as the hybrid data, the local data that we're providing before we make application to the state for a less restrictive level. We don't have a choice, as we talked about before, in terms of where the state dial falls. That is going to define the restrictions that at a minimum we have to operate under. So we don't have a choice there. But there is still decision-making that would happen by this board. And you can be looking at the local data before changes are made. And so while there is some discrepancy in the data, there are some safeguards in there that it's not moving automatically based on that data.
Marky?
Anne?
Yeah. One of the challenges through this whole COVID crisis has been to get cooperation and or consistency between states, between counties. And it's really challenged everyone to deal with the crisis. And I think as we learn more and more, we need to be trying harder to have some consistency across larger areas, across the region. This seems to be a good solution to the problem. It addresses the state system, whereas John just said, where we'll be evaluated. But then if our data itself is a little more fine-tuned, we're covering that too, so that we have something to back up stricter or less strict measures within Pitkin County. So I would think this seems to be a good way to go for now. And I think the greatest value is, and I think Kim alluded to this or said this, some consistency at least this regional level across the counties in the Valley.
Thank you,
Thanks,
Anne.
Ann. Another point, if I could, Marky, we have not had consistency even in our own valley. Other counties, our neighboring counties, have had other regulations than we've had. There has not been that much consistency. And I would ask a question to Josh. Josh, if you were setting the dial based on the numbers, would you utilize our numbers or would you utilize the state's numbers for accurate reflection of our community?
I think they probably would give us a somewhat similar picture at this point. As I said, there's differences there, but I think in terms of where we'd actually land, we'd probably be pretty close to where we are right now.
So what I hear you saying is Eagle and Garfield are using the state meter?
That's correct.
They are. So
Yes, they are.
I'm going to be
With
supportive.
variance or without variance?
I think the only variances that Garfield has right now are around the hot springs, like the big event, or big, what am I trying to say? They have some variances around the hot springs and the adventure park and one other thing. So those are the variances that they have, but they are completely both counties are completely going to the state dial. They're not using their own data anymore or their chronometers anymore.
Thanks.
Yeah.
And Josh, I know that you said that they were very similar or they're close or the end result wouldn't be much different, but my question to you is which one did you think was a more accurate measure of our community?
I mean, our data is more accurate. I think that's why we're working to try to make alignment with the states so that they can also have as accurate data as we do. But yeah, there's no question about it. Our data is more accurate. We have it here locally. We have more information coming in right now. But I think if we can get the state aligned and get them the data that we have, then it's going to make things a lot easier from a data perspective to have the state, monitoring the data for us rather than us having to try to use our data to make those decisions.
Well, the good news is we would still be monitoring our own data. And also striving for consistency. And so the outcome should be try to get to consistency, understand there's discrepancies, and continue to work with the state and our other adjacent counties to work to get together to solve the issue of inconsistencies or.
Can I just ask a question? Sorry. Could I just ask a quick question about some of this, the testing data and how it's being gathered? Because I know before too that there's been some private practice doctors that are gathering their own test results. And is the state and the health department, are you all receiving all the test results of all testing going on in our county right now?
No, we're not. So we receive data from QHN. And so those who are integrated with QHN, we get the results from them. And then we of course get results from AVH and Valley View. But we're not getting every single test result that occurs in the Valley.
Any other questions, Krista?
Well, I guess just a follow up on that, because I mean, at least at my husband's office, the impression was that somehow that their company that they're using is sending somebody these results. So I was just wondering again, if the state is going to get different results than we are because of inconsistencies like this.
And the state will receive results directly from labs. I know some providers are reporting to the state. I think what's going into here, and Tiffany may have more information on this, but I think only ELRs are going into these metrics here that the state is using, and that they wouldn't be using just results that are submitted by providers alone, if that makes sense. And then I want to clarify too that we receive all positive results from everyone. We just don't get all negative results.
Okay, any other further discussion on this? Can we get consensus on direction amongst the board members? Move forward with an outcome of consistency with the state, as well as continue to monitor our own individual data and continue to seek alignment. Is that, do I have support from the board members? If so, can you raise your right hand? And I'm going to need, thank you. Okay. Brent, did you vote? Okay. Okay.
Good, absolutely.
Okay, we've got support from the board. And let's,
Marky,
yeah.
if I could real quick, yeah, the quest for consensus and the quest for simplicity is it's pretty elusive, but I think we're on the right track. The thing that concerns me, what I just heard, is that if we're not certain if everyone collecting data isn't reporting it and it's not getting to us or getting to the state, that just seems like a waste of energy. And I'm just wondering, should we be trying harder to get everyone who's testing to get their tests into some sort of integrated database so we can have, will that make the data more accurate and would make us more trusting and make us more consistent with the state? Just a question for those experts who are here.
Well, it'd give us a better idea of exactly what's going on here.
Yeah, sure would.
And this is Tiffany, just to chime in that is an issue that the state is aware of and that we're working toward statewide and certainly in Pitkin County. So like others have mentioned on the call, we are working to get better reporting data and getting more providers on board and getting some of these systems in place. That is something that we're working toward. That's something that the state is aware of. They're aware of some of these inconsistencies when they are determining these levels. So if we were ever to move between levels, they would take that into consideration. So it is something they're aware of too, and that it varies by each county, and that we are working to get these systems in place, as everyone's mentioned, so that we can have consistency and better data reporting. So it is something that we're actively working on.
But Tiffany, please, I mean, like, this is a small town and there's only so many providers here. And like, my husband's one of them and he wants to share this data. So we can make this happen easy and fast. We just need to figure out how to get the right people to talk to each other.
Yeah, and maybe that's a good conversation we can have, offline. If you have any questions for me, we can certainly talk about that and get into more specifics. There are some specific procedures we could use.
That would be great, Tiffany. Thank you for volunteering your time, Krista. Greg, and I would suggest that we have some medical staff leadership out of ABH as part of that discussion as well.
Before we move on, I was just thinking at some point somebody will have to decide what all we're going to share of this data on the first level with somebody who wants to take a quick look to see what the meter says. This is a really hard, amount of data to absorb and understand right off the bat. So I'm hoping what we're actually sharing publicly is simpler with links to the more complicated additional metrics. But I'm hoping this isn't the presentation we give because it's a little baffling. So simplicity, once again, is something to aim for. And I think we're on the right track and I support where we're going. I just want to make a pitch for simplicity.
Thank you very much, Greg. Okay, any further discussion? Oops, I'd like to move on. Karen?
Can you advance the slide to, so we've done that. Okay, so now we're into the measures. Again, the measures are the social distancing and reduction of transmission of disease that associate with each color. And so we just wanted you to be aware that the team, and they'll talk a little bit about this, went to a task force meeting and got some input from community members on, should we keep at our certain group size that we have in our own public health order? Should we look at the state's public health order? So this is just to share with you that we've engage the community and the sectors to hear from them as well in some of this decision making. I don't think I'm going to have, sorry, Larissa, I know you put work into this. I guess if you want to talk through it really briefly, I just know we're getting short on time and I want to get through the next decision we need to make. So can you just give a quick overview of this?
Yeah, I think you can see the slide, what the general consensus is from the community, but we just wanted to make sure that the community has their voice heard in this decision making. And basically we're pretty much aligned with the state on all the measures really except for events. So that's really where the big discussion has been around. And so we did have an events, arts and culture task force meeting. There's been some lodging task force meetings. So it's kind of all encompassing with some different representatives, as you see there on the right of the screen, that attended this meeting or have responded to these survey questions that ACRA put together. So as you can see, again, just the general consensus is from the community that they would like to kind of align with the state and the measures that are with that.
Thank you.
Marky, it's Patty.
Okie dokie, Patty.
Can I ask a question?
Sure, absolutely.
Yeah, I think we need to clarify with this for the general public. This is formal group size, not casual. So people don't say, oh, I can have 50 people at my backyard barbecue. Because at first blush, when you read that, that's what somebody could take away from this, looking at this survey result.
Yes, thank you, Patty. That's correct. This is for those formal events, indoor, outdoor events.
Right, but it's not clarified on this slide. And I think people, if somebody was to pull this up, they would look at it as any group size. So maybe we need to put some kind of, disclaimer on that this is for formal group events, not for casual. Because I don't want somebody who's having a barbecue to pull this, find this slide and say, oh, this is what I can do.
Okay, let's move on.
Marky, can I just say one remark?
Yeah.
Yeah, I just wanted to say that the medical advisory team has felt that group size is one of the most important and critical variables in spread. So the bigger the group size, the higher the risk of spread. And just to make that really clear that this variable alone is really critical. And in aligning with the state, which the state is higher, and Pitkin has done the public health and Karen has done an amazing job keeping that number lower, and I think really controlling spread. However, given that, if we do align with social distancing and mask wearing within these events, that it should not be spread. But the MAT sees it as one of the most critical variables.
Thank you. Okay.
Thanks,
Karen.
Okay, next slide, please. So again, this is a SNP. Can you a hyperlink on the link to full table just so people have the full perspective. So again, these are the measures that are associated with each color. And you can see that there's recommendations, or not even recommendations, they're actually what you have to follow at each level. So they're not far off from our own, roadmap that we've had in the past. As Larissa said and Kim said, the one thing that's a little different for us right now is group size. That's formal group size. But otherwise, we are pretty much in alignment in the safer level 2 with what we have going on in Pickens County right now. So our, if you go back to the presentation, please. So our recommendation is to align our measures with the state measures, because if we're using yellow in the state and the state says you're ready for yellow, we want to make sure that we're using the state measures then that are affiliated with yellow and not getting the community confused about differences. But to Kim's point, we always have the ability, we reserve the right to make something more strict than the state. We can't be looser than the state. So this is all baseline again, what we're seeing here. But if for some reason we were seeing something happen in our community that we wanted to respond to, we always have that ability. I just want you to remember that and be aware of that. So the decision point is to go ahead and move toward the state measures that then line up with the state metrics.
Okay. Next.
Yes, Marky, if we can just get a quick vote on that, just so we can.
Okay, any conversation? Any questions? Raise your right hand if you're in support. Okay. Unanimous. Let's move on.
Looks like we may have lost our, oh, there it is. Okay. So the next decision point is then remember that we have the measures are the social distancing and disease transmission reduction. Then the public health order affiliates or associates with those measures and it's in essence the enforcement tool around those. So right now we have been slowly over time aligning with our public health order with the states and are really closely there. But there are a number of things that we feel like are really unique to our community that we want to retain. And so those include the things that are listed on this outline. So that's face masking, and to have that regardless. So for example, in the state measures right now, if you get into public, protect our neighbor, you don't have to have mask anymore. And so that's something that they've taken out of a requirement, even though it's a state level requirement right now. If you get there, your community doesn't. We feel like masking is such a critical part of disease containment that we would like to retain that in our own public health order, even if we got to protect our neighbor. We want to continue to require businesses and event safety plans, because that's really been a good communication tool and a way to work with our businesses. And it does give us a little bit of an enforcement tool if those are violated. We want all businesses and community members to comply with and cooperate with case investigation and contact tracing. That's how we box it in. That's how we keep chains of disease transmission limited and not having big outbreaks. We still want all residents and non-residents and visitors to follow local isolation and quarantine measures, that visitors are symptom-free 10 days before traveling to Pickens County, and that we still elevate the 5 commitments to containment. And that we would take reservations for visitors, that they would be aware of 5 commitments of containment, cooperation with case investigation, isolation and quarantine requirements. So these are exceptions to the state order that we would like to retain in our own local order.
Greg?
If this is the right time to ask questions on this, just on the requirements of businesses, maybe requirements of the guests also. Just thinking, is the 10-day prior to traveling the standard we see everywhere, or if you could just describe the 10-day prior symptom-free requirement? Is that what we're seeing elsewhere in the country? And then the second question I had was regarding hotels and hotel reservations, I think that the hotels in particular should be requiring their guests to assume liability for hotel costs if somebody gets stuck here and has to be quarantined, just so we know who's paying for that.
Yeah,
And
thanks,
is
Greg.
this the
So-
place to talk about that?
Yeah, it is. And I'm gonna turn it over to Jordana and let her and her team talk a little bit more about all those things.
Thanks, Greg. So your last question, the visitors that are here and are required to stay longer due to that last point of isolation and quarantine requirements would be required to pay for any additional cost that is incurred due to that in this public health order. So that would be included. And then to your other point of what are other places is a standard. Larissa has presented in the past about what are traveler restriction measures that are being taking place across the country at both the state and the local level. And as you know, last time the Board of Health was here, we are advocating for additional traveler requirements to happen at the state level. But what we've found is we think that this is the most effective one that we can actually ask for at the local level, is just letting folks know that if they're sick, we want them to be symptom-free 10 days before they come here, and being able to message that to folks. And that could still play into whatever happens at the state level could go on top of that.
Any further questions? Okay.
Wait, Marky, I have a question on the 10-day prior.
Yep.
How do we enforce that? I mean, if hotels aren't having people sign anything when they check in, we haven't, I don't think we've done that form. We talked about many times to have the hotels when their guests sign in, that they sign something. I just don't know. I mean, it's not that I disagree with it. I just don't know how we enforce it. Any thoughts?
Shouldn't that be something up to the individual hotel? I mean, maybe there could be a statement that guests should be aware that in the event of a quarantine, they may well have to shoulder those expenses. But it's really up to the hotel and their contractual arrangement with the guest, as opposed to, it seems to me, some public order. I mean, that.
No, I'm not talking about paying expenses. I'm talking about being symptom-free.
Right.
I mean, it requires our guests to be our visitors to be symptom-free, but how do we require that? I mean, we would hope that they would be. We hope to get that information out that we're asking them to be, but how do we enforce it? If the hotels aren't having them sign anything that says, I have been symptom-free for 10 days prior to traveling here. I mean, I don't know.
Patty, can I respond to that?
Yes, please.
Yeah, I think throughout the pandemic, that's one of the biggest challenges on all of these orders and requirements that other states have as well. This was something that the MAT did recommend to public health, and we felt that yes, it is impossible to completely enforce that. But when you ask it, you're going to get a percentage of people who do play by the rules, and you will get some people who will not travel here and prevent some disease spread here. You will not get 100%, but we did feel that it would make a difference, and having that clause in there does make a difference.
So how's getting that word out to people who are traveling from Kansas by car and coming here? And how do they know that there's no sign flashing on the highway that says wear a mask and be symptom free? So I mean, that's just a question I have. Tori and I talked the other day about having the hotels have some kind of form that we've talked about that before, something they could sign. And I thought that was a good idea because I know other places are doing that. And I don't know if maybe some hotels are doing it voluntarily, or maybe that's something we should consider being a little more active on.
And I do agree. I think the hotels can be proactive on that as one solution.
I don't know if Kara is on here, but there is currently a grant that's being applied for by some of the local chambers to work specifically on messaging to visitors. So public health is a part of that conversation, and it sounds like there's a lot of interest around this. So maybe we can come back to this group with after we through that, what some of the measures are that we're working on jointly with our local partners.
That's a great idea. And Tori and I both sit on the ACRA board, so I think I'm going to volunteer Tori and I to help you out with that.
Okay, good.
And maybe just one thing I would share is I know for the Board of Health agenda in 2 weeks, it is we're bringing the communication strategy forward to the
Okay.
Board of Health for winter marketing and can loop some of the same discussion in and bring it forward.
Great. Thanks,
Great.
Carol.
Patty, it's a Northwest COG grant, so I have to talk to you about it anyways.
Okay, let's talk about it.
Okay, Greg?
I just want to make sure that if we do initiate something like this, that the hotels are pushing this out with the reservation. So when the people make the reservation and put their money down, they're getting this information at that time and not when they're on the road and not when they're rolling into town.
Good point.
And Marky?
Yeah.
Yeah, as we saw this summer with lodging numbers down, but more people in town, it's Airbnb and all the other short-term rentals. That's another challenge, but maybe, Cara, in the communication plan, you can address how we capture all those short-term rentals and get whoever is managing those to get the message out.
Good idea. Okay. I don't think we need any action on this other than it seems we have consensus around this direction in the conversations that have occurred. So Karen, do you, is that what you take away from this?
Yeah, I guess just, is everybody in concurrence that we will retain our own public health order to have these items in it, maybe with some refinement of the language.
I didn't hear anyone disagree, so speak if you disagree. I think we just go with it. And I look forward to ACRA and to the work that Jordana and Cara are doing on the winter marketing. So, okay, let's move on.
Okay, last decision point here. We're getting close. Okay, so this is around process. And as John mentioned, right now, the way that the process works with the state for the state dial is that we have to look at our metrics and they have to remain at the same level for 14 consecutive days before you're able to apply for the next level. So that consistency across 14 days. And so as I mentioned, yesterday was the first day that we had the opportunity to look and even move the dial. And we weren't eligible yesterday to move our dial based on that, the top incidence rate. So what we would like to propose to the Board of Health is that during each Board of Health meeting, we'll present the state of the state metrics, as well as our local metrics, just so you have that more fleshed out awareness and trends that we're seeing. So having a good sense of, what we might anticipate is coming, or if we've been in, if we were ready and have a good sense that we're not seeing like something on the horizon like Halloween that might trip our numbers up. And so we will present a recommendation to the board, and then the board would give us direction as to whether we should apply in moving the needle at that point. So if we're eligible to move the needle in a less kind of restrictive way, that we would ask the board to give us that guidance, and then we would go ahead and do the process for application. If we are moving into a more restrictive process, that's a whole different ballgame. That's really CDPHE saying, hey, your numbers are not in compliance. They're not looking good. We're going to give you 2 weeks to mitigate, and then we might give you another week to mitigate, and then we're going to move you into that more restrictive color. So that's not really a conversation. I mean, it's a conversation around mitigation, but it's something that the state will dictate versus on the looser end. We want to bring that to the board and just get your support on that.
Any questions? I'm looking for hands. I'm not seeing any hands go up. So thumbs up if you concur with this recommendation. And take a quick, everyone's fine with that consensus. Okay, let's move on. Aaron? What, Karen?
I said this slide's redundant. This is just where we are of yesterday. We already talked about that. So we're still in safer level 2.
Okay. Important winter planning. Is this John Peacock? Okay, John.
And I know we've got a lot to cover. I just note that we're part of really two conversations at this point. One is at the state level, and then another at the local level. The state has put together a a working group through the governor's office to develop state guidelines for ski areas. Those are very much still in the works and still in draft form. I will give the state credit. They had produced an initial draft and there were a lot of recommendations for amendments to that first draft. And so the work group is working through those now. The work group will probably have, I'm guessing, a few more weeks of work. And I expect draft guidance. I think draft guidance was issued to local public health agencies earlier today, and will be going out to industry and community for comment. So we'll keep you posted on those timelines. In the meantime, we've been continuing to meet with our local partners, particularly the municipalities, RAFTA, ski company, public health, to move forward in parallel with our own local planning based on what we know. Obviously, those two are going to have to come together at the end of the day with the state guidance, but those conversations have been moving forward with what kind of requirements and guidelines and capacities we'll need to have to serve our winter seasons. So we don't have anything to put in front of the Board of Health in terms of those recommendations yet, but I just wanted you to be aware that both of those planning activities are moving forward. And I think we're making good progress on both fronts now.
Any questions for John? I don't see any hands. I see one. Tori?
Thank you. John, is there an opportunity for an update on testing and testing strategy? Maybe it's premature. I know you've been having a lot of meetings and looking at different suppliers and testing agencies. Is there an opportunity to talk with the Board of Health about that?
We have that as the last agenda item.
Thank you.
Yeah, so we're going to be coming to that, Tori.
Yeah.
Hey,
Okay,
Mark,
Greg. Yeah.
Only regarding the restaurant conversations that have been had. Do we have enough people from the community participating in that? Do we have good representation from the restaurant community, and are they? I'm not sure who's on this call. I can go and look at the list, but I just want to make sure that's going smoothly, that we know that they're being heard and they're being able to provide input.
So Karen, I think you and Jordana had were part of the initial conversation, and then there's some ongoing. So Greg, the ski area planning or guidelines that the state's working on wouldn't necessarily affect restaurants in the community, just those operating on the mountain as part of the resort. So the restaurant conversation is one, you all just made some decisions that will define what restaurants are able to do under the state guidelines and such. And then really it turns to how do we support the restaurants to ensure they're operating according to those state guidelines and hopefully able to replace some of their capacity. Karen or Jordana, do you want to speak to Greg's other question about the conversations that have taken place?
Sure. So we did have a restaurant tour convened meeting. Tori was there, myself, Jordana, Kurt, and Brian. had a robust discussion with restaurateurs. We're able to hear some of their concerns and interests, and Jordana has been following up on a lot of those pieces, so I'll let her talk to the specifics. But yes, we're continuing the dialogue and really trying to think about, as John said, there are certain limitations we have that are limitations within the state program, and we're trying to help the restaurateurs think about how do you make this effective and work for you. But Jordana, feel free to jump in there.
Sure. So additional ways that we are working with restaurateurs, we got a lot of feedback that we could improve our communication systems with them. And the best way that they want to be communicated with is when everyone submits an event safety plan. We then have their email. So we've been using the restaurant specific emails to be communicating out with them as we learn about updated guidance from the state, as we develop additional resources that might apply to restaurants or specific sectors. We're creating those same communication strategies. And if folks are asking for additional information, we are working more on that push strategy. So I'm happy to connect offline on any additional details that you'd like.
Great, thank you. Glad to hear the communication lines are open.
Yeah, I have to comment about Snowmass Village. Our marketing and tourism department are creating some very interesting strategies for winterizing what I call the community in order that we can have wonderful outside dining. So you may want to talk to our tourism department. Just amazing work. Okay, let's move on.
Okay, can we get back to, so Marky, I'm just going to do a quick time check. We have two different big things left on the agenda. One is that we have a budget 2021 presentation for new board members. You might not be aware, but the Board of Health plays a role in our budget statutorily. The Board of Health needs to review the public health budget by a certain date. And then, but they are not the approvers of the budget. The budget then goes to the Board of County Commissioners, and the county commissioners are the approvers of the budget because the budget lives in the county and it's regulated by the Treasury, or the treasurer, I should say. So I just wanted you to be aware of what your role is to look at that, give us any thoughts or things that you want us to bring forth to the Board of County Commissioners. So it's a review of our budget, and we're presenting it to you in the way that we present it to the Board of County Commissioners. So this is the style of the county. This is the process of the county. And so I just want you to be aware of that this is the structure that we use for the count to bring it to the BOCC. So, so we have that. And then we also have a testing conversation that we've added to the agenda to address the concerns that we've been hearing through the week. So we have Dave Ressler on the line as well as Dr. Levin to talk through that more. And so I'm just trying to figure out balance of time here and how we can potentially get through both of these by 3:30.
Okay, yeah, let's go for the budget and so
Marky, I would really like to do, testing is critical right now. We have been getting emails and phone calls from people.
Patty, let me
Okay,
finish.
but I just want to make sure, because I'm going to see the budget in a couple of weeks. So I know I have a priority here, and testing is my priority at this point. But if the rest of the board, because I know how we get, and I just want to make sure we have time for testing, because I don't know what to do with these people who are calling me and sending me emails.
Well, we're all getting them. And so the point is, we do need to get through this budget before it goes to BOCC. So the thought is it was allocated a half hour. And if we can do a hard stop at 3 o'clock, then we can get into the testing. Okay. And I think Connie's going to walk us through the budget, right?
Connie's going to, I'll do a fast run through, and then Connie's going to go through the numbers. So next slide, please. So again, just a reiteration, you all know this, so I won't spend time on it, but we do have a mission, vision, and values and equity statement that we root our work into. Next slide. I want you to be aware of the org chart, because we are looking at some two asks for 2021 in FTE. So just a reminder that the blue are staff members that existed pre-pandemic. Many of those staff members are not doing the work that they used to do. They are almost fully, and I will just say for myself, I'm probably 99% in pandemic response, and the work that I did and the job I did before is, either it's been put on hold or I work a lot of extra hours to get that work done. And that's true of all the staff. So I just want you to be aware of the blues are folks that were pre-existing, and then the purples are all COVID-19 related team members. So just for your awareness there. Next slide. So we are going to be having two asks for the 2021 budget. And I will talk a little bit in detail about those positions, but you can see the lighter blue outlined areas. We have a mental health analyst position, and I'll give you some history on that. And then we also have a OWTS permit tech. That's going to be a temporary position. So both of those, one is term limited, the mental health analyst is, and the OWTS permit tech is a temporary position for the year. Next slide. I won't spend much time on this. Just a reminder for those of you who have been through this process with us. In 2019, we were looking at public health transformation. We did a really robust analysis of our FTE and our capacity within the department, and determined that at that time we actually needed to scale up the department to be right-sized between 13 and 16 FTE, and this was pre-pandemic. So just a reminder on that. Next slide. Core public health, you're all aware of these, hopefully by now. These are the mandated services that we are required from the state of Colorado to provide in the community. Next slide. This is the core, it's a new framework for core public health, but again, it's sort of redundant to the last slide. We did an analysis, as I mentioned, in 2019. We recognized that 45% of our core public health services were being implemented. That's also in reflection of just a growing department. Reminder that the department is new as of 3.5 years ago. As I mentioned, the right size, and that we would need additional resources to really get to that full implementation. So that was our 2019 analysis. Next slide. Okay. And then of course, with COVID, things have really changed. So there are a number of different things that we've taken on this year in regard to COVID. Some really new endeavors like having an EOC activated, and also being part of an incident management team, which was a pretty big jump for us to move into an IMT structure. And just a number of different things that we've expanded on because of COVID-19, including a lot of trying to be more culturally competent in the work that we do, language, cultural competency, and all the pieces that we're working on. So again, just an expansion of our work and really trying to prioritize some of these core public health services in response to COVID-19. Next slide. You've seen these goals before, so I won't go through them, but just a reminder that we're working toward these goals in response to COVID-19 in particular. Next slide. Okay, so I'm going to turn it over to Connie now.
Okay, good afternoon, everyone. This slide shows a 3-year comparison, the 2019 actual results for the Public Health Fund, the original 2020 budget before any of the emergency supplemental requests were approved, and then the proposed 2021 budget. You'll notice at the very bottom of this slide, the change in FTEs. 2 new FTEs were approved in the 2020 budget, going from 8 to 10 FTEs, plus there is a quarter of a financial analyst position, which is shared with the Human Services Fund. There is a recommendation to hire a financial analyst just for the Public Health Fund. So the quarter of a position would go back to Human Services, and a financial analyst would be added to the Public Health Fund. Then early on in the pandemic, the county added 12 new FTEs for public health. And as I mentioned, the request for a financial analyst plus 2 new positions that will be coming to the board in October. And then, as Karen mentioned, another position on top of that in the 2021 budget brings the department up to 26 for the year. That's why you see the 152% increase in personnel costs. For the professional and technical services, the largest increase there is due to the harm reduction grant, which was awarded to the Public Health Department. There's about $200,000 extra in contract costs, and the harm reduction grant goes along with the co-responder program. There is also an increase, a requested increase from Community Health Services for their immunization program. Other services include phones, travel, motor pool, training, but the largest increase in other services is $25,000 for advertising. The intention on this is giving capacity for example, a flu shot advertising campaign or any other advertising campaigns that the Public Health Department may need. In supplies, the increase is a placeholder for COVID response supplies. So those are the main increases in the fund. Obviously, it's quite a large change from the original 2020 budget to 2021. Very understandable given the pandemic circumstances. Next slide, please. This is just a visual of the split in expenditures. 70% are personnel providing the services, and also a visual of the revenues of the fund for 2021. Next slide. This is the 5-year plan that we present every year to the Board of County Commissioners. The reason that we present 5 years is so that given inflation factors or what we know about different revenue streams or expenditures, what will it look like over a long term, and what is the effect on the fund balance? We start at the top with revenues. Taxes are the tobacco tax. We originally put a budget in of $300,000 in 2020 when the tax was first approved, unsure of what might actually come in. Now we think the level of revenue is closer to $180,000. Intergovernmental includes grants, and as mentioned before, the largest increase there is the harm reduction grant, which supplements the PACT co-responder program. That's $320,000 more dollars in 2021. And there is also $152,000 for an ELC grant. In a normal budget year, about 35% of the public health fund is grants. Licenses and permits, there's a fairly large increase in environmental health. This is assuming that new rates get approved for on-site wastewater treatment systems. So overall, about $1.4 million in revenues. The expenditures I spoke to on the previous slide, about $4.1 million in expenditures. The difference is made up by transfers. There's a $1.7 million anticipated transfer from the general fund. Most of that is taking CARES Act money that the general fund will receive and passing it through to public health in order to support all of the COVID response positions. The Healthy Community Fund supports public health with a percentage of the fund. And so the $698,000 is simply the percentage allotted to public health from the Healthy Community Fund. And then the mental health position that Karen mentioned, which would be new in 2021 for a 2-year term limit, would be paid out of the mental health contract, which is located within the Healthy Community Fund. That leaves a net deficit of just under $192,000. And this would come out of the fund balance, out of prior year savings in the public health fund. It does leave the fund balance a little low in 2021, but we think that with support from the general fund, we'll get up to healthier levels in the coming years. Can I answer any questions?
Margie?
Yeah, go ahead. Yes.
Yeah, so the budget between 2021 and 2022 changes dramatically. Do you think we're going to be all done with COVID by 2022?
That I certainly don't know. The positions that were hired during back, I think it was in April that we took the supplemental to the commissioners, were all term limited, slated to end at the end of 2021. That's why you see such a large drop. Whether that's the case or we need to extend those, I don't know.
Okay.
That's what was originally proposed to the commissioners.
Yeah, our planning was for an 18-month period for COVID response. My sense is over the next 6 to 9 months or year, we're going to continue to learn more about the trajectory of this pandemic and what longer term or shorter term needs are going to be, and we'll have to make adjustments. But we've been in this for 7 months now, so predicting 18 months out is pretty difficult. So right now, we've planned this out for an 18-month response, and we will see where we're at and have to make adjustments.
Okay, and when would you go back and evaluate whether you have to make adjustments? 6 months, 12 months?
Well, I think it's an ongoing process. The county has a budget supplemental process where we reevaluate quarterly. And in emergency situations, we will go in between those quarterly updates. So, you know, at a minimum, and I think that was Ann asking that question.
Yes, it was. Sorry, Dan.
We're reevaluating our budgetary needs on a 3-month basis at the county.
Okay, then one other question. The mental health RFP only goes 2 years. Is that an IGA that only goes 2 years?
Yeah, and we'll talk a little bit more in detail about that position, but that is that's that collective funding RFP that we have with the city of Aspen, the school district, and the hospital. And we had some surplus savings over the last 2 years, and that group met, the strategic committee met and recommended that we allocate those dollars toward a 2-year term limited position. Yeah.
Great. Thank you very much.
Connie, go ahead.
That's all I have. Any other questions?
I'm looking up and down roster here. I don't see any questions from board members. Okay. Karen, do you have any additional comments relative to your budget?
We were going to hone in on some of the changes that were being made. I would say that, you know, we have 10, you've given us 9 minutes. So is it worthwhile to talk about the mental health position or the OWTS position? Those are the unique staffing positions that would change in 2021, or if there are any questions about any of the expenditures that or revenue sources that Connie mentioned. Other ways we might skip the full presentation at this point.
Why don't we just send that budget out to all the board members? I saw it earlier today and everything made sense. The 2 positions just plain made sense. I'll see if there's any questions from board members. If not, on a very 40,000 foot level, do we have support for this budget moving forward? Or would you prefer for us to act on it in 2 weeks from now, Karen? Greg?
Karen, if you were going to weigh in on that, but I can go after.
Yeah, I just wanted to get the timing for Connie because I know it's coming to the BOCC and there's a element to that. So Connie, can you help remind me of?
We'll be presenting the full county budget to the commissioners on October 13th. And then 2 weeks after that, on the 27th, is the presentation. So we've got until before the 27th of October.
Yeah,
Marky,
Greg. Yeah.
If we could, since we have John here and we have Connie here, it always helps me when we're looking at our budget to understand what we have in the way of a cushion. This is a huge increase in our public health budget that we didn't anticipate before this crisis. And I think it might help the Board of Health to understand where we stand financially in a nutshell as a county, and our ability to absorb this sort of expense. And I'm always grateful when I'm told that our contingency fund, we have requirements from the state as to what level contingency fund we must carry, and we generally have more than double that. But I'd love to hear confirmation from John or Connie if that will help.
Yeah, so Greg, without going into all the details, because obviously that's complicated, the budget that we will present to the board for general fund and all funds does maintain those healthy fund balances in excess of GFOA recommendations. So there's obviously a lot of detail behind that we're going to spend time discussing, but we do believe that we've got a plan that maintains healthy or reasonable fund balances for all county funds in 2021 through the 5-year plan. Obviously, we've had to make some challenging choices in there, and you all will have an opportunity to revisit those from October through December. But yes, we are maintaining healthy fund balances.
Great, thank you.
Okay. So if we could, so let's send this out to the board and go, and the next meeting we will take any final questions and then recommend the budget to the BOCC. Okay, let's move on to testing.
Okay. All right. So we'll bring back the other slideshow. Thanks, Raleigh. So I just wanted to set the stage a little bit for the Board of Health as well as the community on testing. I think that there has been, well, I know that there has been a real discoordination at the federal level early in the pandemic. We saw that CDC had a hard time even getting the first test out to communities. It was a real challenge at the federal level to have even a test that worked right from the beginning. And I think that because SARS-CoV-2, you know, it's a new virus to all of us, that the testing modalities and the testing process has been a little bit, it's been fragmented across the nation and it's been iterative. So we've seen that, you know, we started out with the nasal or oral pharyngeal swabs that had to actually be sent to the state lab. And then they actually had to go to CDC to get firm confirmation that they were positive. That was the first thing that we ever did in the pandemic. And so when I think about where we are with testing as a nation, and then where we are testing as a state and where we are testing as a local, it's definitely been an evolving process, and the testing landscape seems to shift and move around really quickly. And as you're all aware, you know, there were the PCR tests, and then there was the antibody test, but not sure the value of those. And now there's antigen tests. And so it's just been the kind of testing modalities and the access, the supply chain issues. And so just kind of recognizing like, wow, there's been a lot that has changed around testing. And we still even see, you know, we just found out the state lab today still has a turnaround time of 7 to 9 days, which doesn't help any of us. And that's because CU Boulder is taking priority with their outbreak. So, you know, it just shifts, it shifts so quickly, and the dynamic shifts so quickly. But I think from a perspective that the state, we asked, and I think the municipalities wrote a letter, we wrote a letter and really asked the state to have a unified testing strategy, you know, that there was something that was sort of blanketing the state and real leadership. And we got a little bit of a response to that. But I feel like that's still a little bit lacking on the state level of really looking at a unified point of care, rapid testing process for every single community. So, you know, in this community, I think ABH really stepped up to fill a gap in testing in this community, and that we, you know, stand in partnership with ABH in thinking about how we can provide testing for this community, recognizing that there's a lot of, you know, spaces for all of us to learn and to evolve into better systems. So with the lack of CDPHE kind of leadership around a statewide testing strategy, we really tried to fill the void in our own community. And so we're here today to kind of talk to you about what is the current state and where we can move forward to make testing better in our community. So I'm going to turn it over to Dave Ressler, the CEO of the hospital, to talk through this. And I think Dr. Lovin's going to speak too. And I just, again, want to bring you all up to speed on where we are and where we're going. And hopefully that will help to answer some questions, recognizing that there's, you know, probably some communications that we continue to need to do within even our own structures and certainly to the community. So Dave, are you ready to go?
Karen, I'm going to start first.
Okay.
Thank you. Yeah, and thank you so much for introducing that. I'd like to start just showing some data over the past 2 weeks of the type of testing that we've done. And Raleigh, do you mind just going back? And I'm sorry, because originally these slides were set up for a full data presentation, as you know. So I'm just going to go quickly through some of them just to focus it more on a testing conversation. Oh. Let's see here. Yeah. So if you go back one, just a little broader picture here. This is the incidence of COVID-19 in Colorado, and you can see there was really a spike since Labor Day weekend, very similar to the middle of the summer. So next slide. And then this is our 2-week cumulative incident rate. If you see Pickens County, we're in the high, and as Josh had discussed that earlier, we've gone up to about an average of 14 cases in the past 2 weeks. So next slide. This brings us to the AVH matrix. And I just wanted to show that we are in the cautious phase still. And this is mainly due to the number of tests that we've been doing, so many tests that it has put us up into the cautious phase. Next slide, please. And you can, we have 0 inpatients right now. Next slide, we'll go through the next slide as well. And just 2 employees out with COVID-like symptoms. And the next slide. And then the next slide, thank you. So this slide is the community testing that we've done. So there's there's several different types of testing that we're doing at the hospital. For the general public, if you have mild symptoms and you do not need to be actually seen by your doctor, you can get a test at the community testing site. And this is the site that we have done over the past 2 weeks. If you look at the dates down below, and we've actually spiked to the highest number per day and per week over the past 2 weeks compared to in the summer in the middle of June and July. So that'll explain it in the next slide. This is actually weekly, so it's a little bit of a broader picture of the number of community testing that we've done at AVH. The 132 in 1 week has surpassed the highest number per week in a week of testing, which was 112 back in the beginning of July. And also 115 as well. So in the past 2 weeks, we've really done the highest number of testing at Aspen Valley Hospital. Next slide. I just wanted to show this because this is Josh had mentioned this. What is the numbers and the data at Aspen Valley Hospital? We are, the testing site there is for everyone who is symptomatic gets a test there. And these include visitors as well, not just Pickens County residents. And if you look at this, which is on the dashboard, and the critical level in the red and the concerning level is out of jurisdiction cases. So there's a lot of visitors that are being tested. And again, these numbers are not being put into the state data, which we have discussed previously. But I just thought it was important to point out that we are getting a lot of visitors who have positive levels that are being tested locally and at the hospital because they're symptomatic. And that will increase our positivity rate. Next slide. So this is on the dashboard, and I think this is one of the best slides. Again, this is just AVH data. So this is Picken County residents and visitors together. So the last 2 weeks, there were 15 positives and, sorry, so 15 positives and 332 negatives, and then 12 positives and 247 negatives. And this is the highest number of tests that we've been doing throughout the entire pandemic. It's a total of 606 tests. Now our positivity rate, which again, this is a metric that is important and is being tracked, as you know, nationwide, Colorado and Picken County. Our positivity rate was very low. It was 1.15 on August 23rd, and it has gradually crept up. We're right now at 4.46. I think the important point here is that we're under 5%. The goal of being under 5% means, and looking at a rate versus gross numbers. So the rate being under 5% is the goal, which tells us that we are testing adequately in our community in terms of symptomatic and asymptomatic people, in terms of a measure that's been set by nation and by the state and how the number of tests required. So the more tests you do, your positivity rate hopefully will be set below 5%, which is where we are. And next slide. So these are the numbers. Again, 606 tests over the past 2 weeks, 247 of them were at the community testing site, 42 at the Respiratory Evaluation Center. And the difference, just to explain again, is at the Respiratory Evaluation Center, patients have more moderate symptoms and need to be evaluated by a physician in person. And we've done that. We've centralized that at the hospital so that the various clinics in the community don't need to actually be seeing symptomatic patients, so that they can be seen in one place and to conserve PPE. And then 317, that was a total from the emergency department, the Basalt After Hours Clinic, the Snowmass Clinic, asymptomatic testing from physician referrals, and also including pre-op and OB. So that's where the 606, and I just think it's really important to break this down to see where these tests are being done, who's getting tested, and that we do have adequate number of tests in terms of our positivity rate at this point, and that our largest testing days were really in this month. On September 14th, we did 27, on September 16th, 31, and that's really what's putting us in this cautious zone in the matrix. So next slide, please.
Where is the community testing site?
Everything's tested at the hospital, again, in just a centralized place to conserve PPE and not spread disease among the clinics. So we all agree that the hospital would take on and have that partnership with public health for symptomatic patients.
Right. That was a question that I got earlier today. Okay.
Okay, yes. So again, and if you look at different types of testing, we're talking about symptomatic patients. And this is why I thought it was really important to bring this model back in. This is the public health model for disease containment and control in our community. And it is the main public health model, and it starts in the upper left with testing. And so anyone who has symptoms gets a test, and the hospital, with partnership, originally with the partnership with public health, has provided that service in the community, and every single person gets a test, and our positivity rate has remained lower than 5%. So once you get a test, and for symptomatic patients only, you are isolated, and if you're symptomatic, you're isolated for 10 days. And I just want to explain again that isolation period, even if your test is negative, there are false negatives. We do ask people to continue to isolate for 10 days. So your test result does not change your behavior or the recommendation on that isolation period. And then you find, so it's contact tracing. And I also wanted to mention, on average, right now, we're at about 5 people that are linked to each symptomatic test. So for every one patient who's symptomatic, there are at least 5 people linked to that case for contact tracing. So it's an enormous amount of work. and public health is doing an amazing job in terms of contact tracing and trying to be as complete as possible to link everyone that's associated with that symptomatic case. And then the quarantine period. And all of this, of course, requires that people that they agree and will that they will agree with the quarantining and with the public health policy. So I thought this was really important. And Dave, please chime in if you have anything else that you wanted to add about this. But again, this is for symptomatic testing, and the original partnership with AVH was to test symptomatic people. And we are up to date on in terms of the scheduling, and anyone can get an immediate test. The other thing I want to mention is the turnaround time, which I know has been an important issue for some people, that it takes 2 or 3 days to get your test result. And that really is limited by the labs right now. More and more, we're starting to get, it is becoming more available to have some point of care testing, and we'll talk about that in just a minute. However, right now, that turnaround time is really nothing that we are limiting. It's limited by the lab, and it takes that amount of time. And again, it doesn't change your behavior, your isolation, just to wait 2 or 3 days for a test result. You're still doing the same isolation procedures. Next slide. So I just want to review how do you get a test in this community? And again, this is for symptomatic testing, and it's not only for residents, it's for visitors as well. And the essential piece of this really is that if you have symptoms, you call your doctor. If you don't have a doctor, you can call Aspen Valley Primary Care, and you will be able to have access to a physician. So really the most important thing is that we have full access for everybody who is symptomatic to get a test. And we feel that it is essential that for many reasons, to address another main issue that I know has come up in a lot of these emails and conversations is, why do you need a doctor's order? There's several reasons. First of all, the labs require it. It's required for insurance reasons. So there's some factors beyond our control in terms of a physician order. And just to process it with a lab, you need a physician's order. And also, just as a physician, it's really important that a physician will be able to evaluate you. There are so many potentially other reasons for disease. You have maybe underlying diseases that may be complicating the situation. You may need additional testing. There's a lot of reasons to have your physician involved in when you get sick. And the other thing that we've really found, especially, I think it's in many communities, but especially in this community as well, is that once a patient gets a test result, there's really a lot of conversation that is essential with your doctor to discuss your result. What does a positive mean? What does a negative mean? And exactly what does that mean to your lifestyle? So having a physician involved is really an essential and critical piece in all of this. Let's see. And we'll go to the next slide. And also, I just want to mention at Aspen Valley Hospital that the test itself does not require any out-of-pocket expenses, which I think most of you do know that we provide the test without any additional out-of-pocket expenses. So again, just to reiterate, for symptomatic testing, which is part of the Box It In public health strategy, that this is performed on-site at AVH just to conserve PPE and to centralize disease so it's not spread among different clinics. For minor symptoms, you can call your primary care doctor and get a referral faxed in and get an appointment. For many people with minor symptoms, they don't have to see a physician. If you have moderate or severe symptoms, we do ask you to be evaluated by your primary care physician, have an oxygen saturation done, have your lungs listened to. And if you have severe symptoms, you can always go to the emergency department for immediate evaluation. It's always available 24/7. So you will get a PCR test, which is either a nasal swab or a saliva specimen. The medical advisory team is intimately involved in this and is guiding testing and recommendations on testing. And again, if you have symptoms, you self-isolate for 10 days, and that is something that doesn't change whether you have a positive or a negative test. Positive tests will be initiated by public health for contact tracing. So all positive tests go to public health. As we discussed, the negative tests are not always reported to the state, but everybody will get a test result if it's positive or negative. And that negative results are not an assurance. So again, you're self-isolating for 10 days, your behavior and does not change based on your test result, and that there are false negatives. And it's always really important to remember that there's false negatives. And we do not retest. So if you have a positive test for PCR testing, we're not going to be retesting, or a negative test if you're doubtful of your result. We're going to go with the initial result.
I think Dr. Kurt had a question.
Okay.
I have two questions. The first is, the state of Colorado, or CDPHE, runs its testing programs in the Denver area with what's called a standing order. A standing order means CDPHE's doctors have written an order so that anyone that comes into that facility gets the test as long as they fill out a symptomatic questionnaire. And the ASTM system, if you look at read the newspaper or letters to the editor, there have been complaints about the expense and the delay of going into a private physician or whatever to have this performed. So why cannot Aspen have a standing order that would be signed by you, Dr. Kim Levin, to have the patient come in and perform the test? Or even I would be willing as a physician if you would allow me to sign such a standing order. The second is, I want to travel at the end of this month, and I need a test performed that would be negative to go to this location that I'm planning to go. How do I get a test performed in Aspen or on the western slope of Colorado if I don't have symptoms?
Aspen Medical Care.
Yep. Thank you so much for bringing up both of those points. And I was going to get to those in the next slide. So I'm really glad that you brought them up. So first of all, the standing order issue is very important. And I want to let you know that there is a standing order, and it works within and it's my standing order that we have. I have a contract with public health and with the county to have a standing order for public health purposes of box it in. So if there's a symptomatic patient and there's an outbreak, let's say, and you immediately need 15 or 18, which we just had recently, an outbreak, people tested immediately to be able to contain this outbreak. They are using my standing order for that purpose. And so again, it goes into the box it in essential public health strategy in terms of containing disease in our community. And so yes, the answer is we do have a standing order. It's under my name, and it is for essential public health practices. Now, the second part, which is also an equally important question, how do you get, let's say you want to travel to a state of that requires it, or you have an activity that requires you to bring in proof of a negative test before you go. You can contact your primary care doctor, and they can refer and order a test for you. It's called asymptomatic testing for specific targeted reasons, and they can order a test for you in this community. And a large percentage of the numbers that I showed before of the asymptomatic tests that were performed even in the past 2 weeks at Aspen Valley Hospital were in that category of people needing a test. They contact their physician, they get a test through Aspen Valley Hospital, an asymptomatic test, and that's part of our overall 606 over the past 2 weeks that I just wanted to give an example of. So both are actually occurring locally at this point. Does that help?
A couple of weeks ago, John Peacock on his visit to Maine mentioned that he had been tested in Colorado Springs. So apparently that was not available in Aspen at that point.
Well, a couple of things to explain.
Can I just be clear about that? Because that's come up a couple of times. My parents live in Colorado Springs. I was visiting my parents with their grandchild, and that's why we got testing there.
And I also want to explain that we are in a rural community. There are very large, what's happening even in the past week, just to explain, there's very large partnerships that are starting to occur with pharmacies and with large healthcare organizations that are having where you can go to a pharmacy. And I think that was at a pharmacy location in Colorado Springs, I'm not sure, but that are making this a lot easier with standing orders from large healthcare organizations. So all of this is starting to happen. And I'm guessing will also come to us, but at this point, we don't have any pharmacies in our valley that have those types of partnerships. And I am sure that that is coming our way at some point soon. Can we have the next slide, please? And I think I went over this basically, except for this last point, which is that there are continued expansion opportunities. One of them I just mentioned, and there will be a lot more availability for basically for asymptomatic testing and for screening and for targeting testing. And we're looking into a lot of these opportunities at this point, a lot of conversation and discussion. We have the next slide, please.
But before we go there, Dr. Levin, can I just make a couple comments real quick?
Yes.
I think it might be helpful to know that while a physician order is currently required, we're going to, as Dr. Levin just said, we're going to talk a little bit more about that for any testing at ABH. We do have, if you could go back a slide, I'm sorry. We do have, as part of our process, we receive faxed orders every day, many of them, from physicians in and out of the area. So people that are traveling here frequently and typically call their physician back in New York or Chicago, wherever they're from, and they just fax in an order. Also, I think it's important to note that oftentimes the physician doesn't require to see the patient before calling an order. Typically, they would want to see the patient if they have if they don't have an established relationship with the patient, is one example, or if they want to evaluate the patient. As Dr. Levin explained earlier, sometimes they may be thinking about other kinds of causes of the symptoms besides just the potential for the COVID virus. So it's a physician judgment issue. In the case of Aspen Valley Hospital, if we have an established relationship with the patient and don't think it's anything worse or more concerning than just testing for the virus, we typically our physicians just order the test. If we do not have a relationship with the patient already, and the physician wants to meet them first, which is totally understandable to build that relationship, we typically do that with a teleconsult, telemedicine it's called. And that is quick and easy. So I just wanted to, and a number of our providers do that as well. So we do understand the frustration, though, that there are some people that don't have an established physician to call and may be concerned about the cost. With our telemedicine visit, it's $66, but it varies by the practice. And it's billed to insurance, but we completely understand they may not have insurance, they may be underinsured, they may be concerned about the cost, they don't have a physician. So we're going to talk a little bit more about that later. The medical advisory team is quite concerned about that dynamic. We want everybody to have access. That's considered an important part of having health equity. So we are going to talk a little bit more about that.
Great, thanks, Dave. Any questions for Dave at this point, or? Okay, we can go on to the next slide.
Publish this information in the paper.
It'll be in there tomorrow, I'll guarantee you, because I know who are some of the participants.
Okay, Raleigh, the next slide, please. Okay, thank you. So this is so now if we shift from symptomatic testing, which is the essential public health piece of disease containment, to asymptomatic testing. And as Dr. Kurt mentioned, there's so many reasons, and he's got one reason for why you would need asymptomatic testing. And your provider is, it is occurring in this community at a significant level in terms of having your physician refer for a test. If you're traveling, it's required for school, for camps, for whatever the reason is. The second piece of asymptomatic testing, which I had mentioned, is the public health referrals, and that is for disease containment, for outbreak containment, and for exposures, and that's under my standing order. And that is currently being done, and I think it's being done very well. I know Josh works very hard and works very quickly when there is a symptomatic person and there is potentially a disease outbreak in our community, to really work quickly to get everybody tested as quickly as possible. And the tests in that situation are going to be tests that have a very faster turnaround rate so that we can quickly really contain the disease. And then the third section of asymptomatic testing in our community is going to be targeted screening. So really defined populations that are at risk, nursing home, senior centers, students, congregate housing, where there's people living together closely, dorm rooms, assisted living, employee housing. And as we all know, in our community, there is a lot of this. So so this type of targeted screening will be another asymptomatic testing. And if we go to the next, which I believe is the last slide. Oh no, sorry, there's one more slide before that. This is to review our testing options, and then we'll go to the last slide, which will address that last point that I had there. So this shows, at first glance, this shows how complicated it's getting and how many different options there are. And this is just some of many that are available in the United States. But here locally, we have in different categories, the in-house testing. So we're using a Cepheid PCR test in-house, and that is the fast turnaround test. So it takes a few hours to do. We also have BioFire, Fluvid is coming down the pike, and then the Abbott antibody as well. So we have a variety of in-house testing. And just to mention, there is a separate group in the hospital, a testing committee that examines this on a regular basis and really chooses and looks at sensitivity and specificities of every test and tries to choose the very best and most available. If you look right under that is our send out PCR test. That's polymerase chain reaction. It looks for the virus itself. And again, right now, and this is probably not going to change, these send out tests have a 2 to 3 day turnaround time. They have to be sent to a lab. The current lab that we're using is Microgen. It's in Texas. It takes a day to send it. It takes a day or two for them to process it. And so that's a limiting time that for anybody that is coming in for an asymptomatic test to just work that into your schedule in terms of the timing. So definitely know that there's going to be a 2 or 3 day turnaround time at this point. Again, things will change and improve, but at this point, this is what we're using. So Dr. Kurt, when you need to go and travel, make sure you get that 2 to 3 day time scheduled into your schedule so that you know ahead of time when you're going to need that negative test to show. And then there's other options in the send out PCR tests, but the Microgen's really doing a great job and we have a really good relationship with them at this point. If you look up at the point of care testing, we are having access to the Abbott ID Now PCR test, and this will help expand testing. So point of care means right on site. It's a piece of equipment that can be put into a site, like in a clinic or somewhere else, and you can run tests on that. Now, it's really important to understand that there are differences in these tests, and these point of care tests, which I believe are going to become more and more available as we go through this pandemic to make it more accessible and fast for turnaround time. They have a lower sensitivity. They have faster results, but they're not as accurate as these in-house lab tests. So it's something to understand and know that the faster and more accessible the test, the less accurate that test is. And that's just by nature. It's for any test. We have the same issue with flu tests, the same issue with rapid strep tests, and the same issue with COVID tests now. And so this will become more available, but there will be false negatives, and you need to kind of factor that into when you get your test result. But they will make it more available and accessible. Yep, go ahead, Dave.
Yeah, first I'd like to let Dr. Kiesel say something, and then I'd like to add some commentary as well. Thank you.
Thank
Perfect.
You may say what I'm going to talk about, but I think this is a really important thing that we gotta like spend some time on for the community probably, because I feel like, there's all these antigen testings and you can go, drive through Walmart in Ohio and get your COVID test. And there's a lot of like, why can't we have that here in Aspen? Because we're Aspen. So I think it's really important, Kim, if you wouldn't mind kind of even expanding on the antigen testing, because I think too, we've done this A+ job here in Aspen, but as we open up the schools and things like that, maybe a B job is okay, as long as we understand kind of why we're doing what we're doing and what else is out there and how we're different.
Thank you, Dr. Giesel. And I would also just like to point out for the benefit of the board and the community that the list of tests under in-house testing are the most accurate and they're the most rapid. And therefore they are in the greatest demand. And so we are manually allocated these tests on a very limited basis. So Dr. Levin mentioned that there is a in-house committee that decides on what patients it's most appropriate to use these tests. So we will use Cepheid, for example. That's kind of our powerhouse, focuses on COVID, but we use that on the most symptomatic patients. And if a patient, if a physician is really concerned about their respiratory status, they may use BioFire, which tests, I think, for 18 different viruses all at one time. But again, we have them in very limited supply. So I just wanted to point that out because we have people that come to the hospital and say, I want a rapid test, I'm traveling tomorrow, so I'd like the rapid test. Well, that's not a good use of our rapid test when we need to make sure that they're available to take care of patients. That's our highest priority. So sometimes we will, depending on the circumstances, but we're very selective. Whereas the send-out tests, as Dr. Levin pointed out, they're not limitless either, because the state lab right now is, actually it was Karen that said they're overrun and their length of time for turnaround has increased dramatically. We've been most pleased with Microgen. So I just wanted to, and one final point. Even on the point of care testing, I just talked to our lab director immediately before the meeting. We have already received 4 analyzers that you see pictured there for the Abbott ID Now. It processes 1 test at a time. We were supposed to get our tests themselves 2 weeks ago. And then we were told this week. Well, this week we're being told next week. And they too are on a manual allocation because they're so popular. So we don't really have a limitless supply of tests in any of the categories. But that doesn't mean we don't have expansion capabilities, as we're going to discuss in a few minutes.
I think that's such a great point, Dave. Thank you. Because we, still being rural allocation, we are not the hotspot top priority for these labs in terms of allocating resources to us. And so we are getting as much as we can and having to really conserve which tests we use, the in-house testing, so that we really make sure that the sickest people and the people who have symptoms, the symptomatic testing is a priority for the box it in strategy. And I just wanted to mention, Dr. Giesel, your comment was really important because it actually really, and this is a conversation when you have a test and you talk to your doctor, what does the positive mean? What does the negative mean? It plays into this conversation of you are isolating for 10 days. And so you can't return to work or you can't get on that plane, even if you have a negative test. You got tested, you got what you needed, but your behavior is not changing. So we can't say because you have a negative test, it's okay for you to go back to work tomorrow, or it's okay for you to get on a plane and travel. We're saying you still have to isolate for 10 days. And so with the school algorithm, there's an entire school algorithm in terms of positive and negative testing, and that algorithm just needs to be followed depending on a positive and negative test, and you'll have more testing become available. But again, it doesn't change what you do. And we need to still stick to school algorithms in terms of who goes back to school and when does an entire cohort in a school get pulled for quarantine. And so all of these have big ramifications. And again, these are the things in our community where testing is most important. It's most important for disease outbreak, for keeping schools intact, for keeping as many cohorts in school to be in school, and using testing for these purposes. On the horizon, I want to mention that there's a lot on the horizon, and we're looking at these different options every day. And I know now, even in the past week or two now, there are some large labs that are offering that you can just go online and get a test because they're now partnering with these enormous healthcare organizations for standing tests. So all this is happening, and I believe that anyone can go online and it does take 1 or 2 days for it to be sent to you. You do the test, then you send it back. So the turnaround time is long. And we all want a test immediately, and we're doing our very best to do that as much as possible for the most important tests in our community. But this testing will become more and more available as we go on and have these different options open to us. I I wanted
And then
to
that
go to
gets
the,
reported, Kim, somehow to the county that the person lives in?
sorry, what's the question?
That after you buy this online test and test yourself, somehow they know how to report it to the county health department?
Right. So Dr. Giesel, that's a great point. So are all of these big labs, are they then reporting? So the large labs are reporting to state health departments all the positives. Some of them are doing negatives, some are not. And so that's why the positivity data on a state level is not as accurate as we have on a local level, because we know all the negatives from Aspen Valley Hospital, we can get a better positivity rate. But again, then you have all the visitors thrown in, which have a very high percentage. As you saw, the out of jurisdiction cases have a high percentage of positive rates. So in terms of calculating all that data, it's all being worked on in the play. There's some labs that are doing it, there's some that aren't, and so the data is not going to be accurate. And then once you have Abbott ID in different clinics, you're going to have positives and negatives that need to then also be put into the system. So there's a lot of work behind all of this to try to get the most accurate data. And that might be like a manual feeding for each physician who does a test on site, a rapid test that has the lower sensitivity and specificity, but is available. And then they'd have to feed that into the system too. So all that is work that needs to be done behind the scenes, which is enormous. Dave, is there any more comment on this side? And then we'll go to the next one.
No, ma'am, thank you.
I have a point. So I have a comment. I think the school district is having a lot of difficulty getting the kids back in school. So what we actually need is a rapid point of care, maybe even a few hours test that is inexpensive for screening. And this will also be important as tourists come in for the winter season to be able to screen them. I mean, we don't have to have the perfect test, but if we can test the teachers and the students, maybe even do batch testing every week, this could be a game changer in getting our kids back in school, which is one of our priorities.
Absolutely. And I'm glad you brought that up. If we go to the next slide, and this fit into a slide before as well. So that type of testing is, especially in the schools, is going to be so essential to keeping as many children in school as possible to fit that model. And so what we're having conversations right now about are a multi-organizational, like that's part of like what we're calling a targeted screening. So screening schools or screening organizations or businesses that may have a lot of incoming people. And so there may be some partnerships being formed, and there's conversations about this right now in terms of creating that very same solution in our community. And we all agree on that point. And so if we look at this, and I like this, Dave labeled this a multi-pronged approach, which I think is really going to be the solution for us. On the left, which is what I really focused on, the box it in strategy is for symptomatic people, residents, visitors, non-residents, whoever has symptoms in our county gets a test, and it gets a test through the process that we reviewed. And that is all in the box it in strategy. And AVH has partnered with public health to provide that service. And we are testing every single symptomatic and a lot of asymptomatic, but every single symptomatic person gets a test and gets entered, the positives get entered into the public health box it in strategy. So the targeted screening is having conversations right now about having a multi-organizational type of partnerships that may be able to achieve this on a very high number and fast, accessible way. And then another way of a third prong to this is just expanding testing sites. And we discussed that with the Abbott ID, that piece of machinery that can be placed in different sites, and really try to increase our testing in asymptomatic testing in that way. But currently, if you need asymptomatic testing, talk to your doctor or call the Aspen Valley Primary Care Office and see if we can get you an asymptomatic test. But the priority, again, is still the symptomatic testing. Your behavior and what the recommendations are from your doctor are still the same, as to isolate for 10 days. This targeted screening is going to hopefully prevent some outbreaks, and also the primary and important goal of keeping children in school. And Dave, if you had other comments on this last slide.
Yeah, I would just add, Dr. Giesel commented earlier, but Dr. Brian Giesel's practice, Aspen Medical Care, is one of the examples of a number of practices now in the community that have they're using all different modalities, and mostly asymptomatic, because they don't necessarily want to invite symptomatic individuals into their practice and potentially cross-infecting their staff and other patients, which makes perfect sense. Our site here, as you discussed earlier, has negative pressure rooms. We have all the proper PPE. We separate it from all of our other patients. So we're a very safe location to be able to test these individuals. But the practices can do asymptomatic testing, and it's good for their patients and good for them. So that's included in that expanded testing site. And then with regard to box it in, I'd just like to repeat what I already said and Dr. Levin referenced as well. We do know that there is still a health equity issue for individuals. We think there are options for them, such as we have a charitable care program at ABH for those that can't afford health care. Mountain Family Health Centers can provide testing referrals. They can actually provide tests on certain days of the week. But we, as the medical executive team, working very closely with public health, are going to explore some additional options for additional sites where a physician referral won't be a barrier. So we don't have the answers now, but we have the intent. We hear the community, we know that's a problem for some, and we want to make sure that we address it. So those are the only additional comments I would offer.
Thanks, Dave. Yeah, and that's really for the uninsured, underinsured, low-income people in our community who cannot afford this. And we consider that part of the public health in terms of providing that service. And we are looking at a lot of different options at this point to be able to expand it for that very specific segment of our population.
Yeah, this is Brent. I know this is simplistic, but isn't the goal, from my standpoint, like Los Angeles, which I believe will test anybody, symptomatic or not, and it's all free? Wouldn't the ideal be that somehow the county can make claims against the insurance companies? I don't know what kind of arrangement we have, so somebody somewhere covers some of this. But it seems to me that if there's ever a reason for public funds, it is to make sure that everybody that wants to get tested gets tested. And then we end up with an abundance of data that we might not get otherwise. You know. And I mean, I know that's a complicated thing, but we've talked a lot here about, going to your physician if you don't have symptoms, but if you have symptoms, you can drive to the hospital, and all these kind of qualifying things. And I know that there's a subset of the population that's never going to do anything that's difficult, and they're always going to be late to the table even if they don't feel well. If testing is pervasive and free, should we strive for that, or is that just something that's impossible out of our hands and we can't do it? However, other places in Los Angeles, of all places, I believe, is doing it.
I don't know what their state resources are out in LA, but California has a whole different program than what we have available to us in Colorado, with limited numbers of tests available and distributed. Dave, you may want to comment.
Yeah, I think this is a really important point and a good point, and I know it's been a lot of the public feedback. I mean, I think you're correctly identifying, of course, that there has to be the capacity. It's not just funding. As far as our test recipients are concerned, they are free. If they're provided through the hospital, they always have a free option. But the point in the middle, the multi-organizational approach, won't be exactly what you're proposing, but the intent of public health and the medical advisory team working with them are to work with our very large organizations in the community where there is a significant amount of critical mass and scale, as Dr. Levin referenced, that would indeed be screening, and in particular looking for people that are in vulnerable situations or where transmission can easily occur, such as tight housing or working environments, et cetera. And so from my own hospital administrator perspective, not being a public health professional, I've been very impressed with the quality of the discussions and the nature of the partnership. That I don't think John or Karen are in a position to start discussing today, because there's a lot of organizations involved, and a long way to go, a lot of details to work through, but the intent is certainly there. And I think that would achieve a high level of critical mass in what you're seeking.
Anyone else? I know our time is running out. Kim, did you have other comments?
I think, again, one last comment, and Brent, I mean, you bring up really one of the most important points in terms of the demand for testing. As a physician, to really examine why you need a test and what are you going to do with that result. And so if you just think of it logically, I know we're in a pandemic and there's anxiety and everybody wants to be tested, but if you look at why, if apart from all of these essential reasons to be testing and really focusing our resources on these essential pieces, a test may not change at all what you do. And then there may be some situations where, you know, you can't get into a state unless you have a negative test. There's rules in other places, and we have resources to test for those reasons. But we do ask people to examine, are you just doing this because it's kind of a fun thing to find out if you have it or not? Or are you really doing this for a targeted reason? And to understand that the result of that test really may not change anything. If you have symptoms, you isolate for 10 days, we ask you not to spread the disease. If you don't have symptoms, you know, if you're looking for positives, this is going to create, it will then be put into the whole box it in strategy. And then you agree to being quarantined and isolated, and your friends agree to be quarantined. And there's an enormous ramifications of a positive test. And we don't retest people. Positive is a positive. And so I think it's really important to think carefully about what the demand is and why individually you want or feel like you need a test, and really consider the resources that we have now, that we really need to target and prioritize them to the highest priorities, which are symptomatic and then these targeted type of testings like the school. So I don't know if that helps out.
Well, it did, and I think, and I agree. It's a different way of attacking the problem, and there's probably multiple ways to do this that are all reasonable. And of course, maybe testing everybody and totally free and, you know, next door maybe would be an ideal. But one thing that you touched on and someone else did earlier, which I think is huge, and that is not only masking and social distance, which we know really, really works, but the fact is that if you have symptoms, you need to isolate. Not forget testing. Get tested if you need it. But regardless, you need to wait out these symptoms, because I do think there's a perception. And in fact, you see it all over the world even. They're looking for a green card or prior to taking a flight, right? And you get the test and it's negative. Number one, you have a false negative of 30%. So you can't trust the test particularly. And then number two, if you're symptomatic, isolate yourself regardless of any test data. And you know, that's
exactly. That is exactly it, that you are isolating no matter what, and that a negative test does not give you a green card, unfortunately. I wish we were in this ideal world where we had these 100% sensitive and specific tests where we can say, yes, you are free now to go back to work and get on a plane, but you're not. And so again, it's very simple. And if you just kind of distill it down to the most simple instructions.
I know it's
pretty great.
I'll take one more comment and then I'll turn it back to Karen.
Because I think that the complicating factor in this, though, and the thing that the community pushes for testing on, is it does get involved in our coronameter. So I completely agree, you know, if you're symptomatic, get tested. But I feel like there's this bigger implication too, that the more information we do have, it does affect us as a whole community and as a whole valley. So I just feel like for the public, you know, I completely understand the doctor side of this because I live and breathe it every single day too. But I think that there is this connection between the tests and the coronameter that we cannot deny, or just we need to be able to explain.
Right. Thank you very much for that comment, Krista and Kimberly. Great presentation. Dave, thank you very much. I'm going to turn it back to Karen because it's 3:46.
Yeah, so we, that's that's what we had for you today. I just want to preface I know we always talk about agenda items for the next 2 weeks. We do have some agenda items we would like to bring back. It sounds like the finality of the budget. We have a communication strategy that will be completed that we'd like to share. And then we also have something non-COVID related, which is looking at environmental health OWTS fees, which is something that the Board of Health has a statutory piece around approving or not. So we're going to bring that back to you as well. And then however you want to lead the rest of that conversation, Marky, but just wanted to put those on the radar screen.
Well, it already sounds like a pretty busy agenda in 2 weeks because we'll be talking winter planning as well. So going to be busy. So if you have agenda items you would like to add, send them over to Karen. And if you could copy me on them, that would be fabulous. Okay, with that said.
I see Suzuho's unmuting, so.
Sorry, Karen's actually going to be out of town for the next one. So if you can send those to me and Marky, that would be great. Thank you. Okay, Suzuho, so thank you for reminding me, Suzuho. Tori?
Thanks. I feel like we're wrapping the meeting. Obviously, we're running a little long. There were a couple of things that I wanted to get to in the round robin portion. I apologize. On the agenda that I got, I did not see testing as one of the topics that we were going to be talking about.
It was added this morning.
It was added this morning.
Very early.
I just wanted to say a couple things and then I'll just stop. But I wish that we had more time for discussion. First of all, I just want to say that the budget has my support, especially the mental health facilitator that is looking to be added to that. I want to support that strongly, and I urge the county commissioners to support that as well as look for other avenues. We are going to see the ongoing effects of what we have faced in 2020 for months and years to come, and the mental impacts are going to be some of the greatest ones that we see, and I think that this board needs to support that effort as much as possible. The other items, and I'm just going to go through them because we don't have time to talk to them. I wanted to know where our other neighbors, Garfield and Eagle counties, were on the dial and if they were going to be applying for moving their status. I wanted to talk about something different than what Dr. Tom Kurt was talking about, departure testing. I'm wondering about arrival testing. I hope as we're building out our robust testing program going into the winter that we have the ability to test people upon arrival as well. I think that would create a level of safeguard for our community that would be wonderful. I also just wanted to go back to what Brent started in the beginning about his penalty schedule. And really, I guess what his sentiment there is feeling that we don't have enough of the quick switches to the back of the hand in order to change behavior. And we only have one large penalty in our quiver, and that may not be serving us the best. So I was wondering if this board should have a voice in that, should have comment on that, or should be talking to that. We got an answer from John Peacock talking about resources and enforcement, but I think that Brent has a great point about what it takes to get people to comply, and I think that could have more discussion. The last thing that I wanted to bring up was that over the last few weeks and truly over the last few months, there have been incidences of poor customer communication at AVH, the hospital, in regards to testing. And I've heard several accounts just receive more from other members of this board this past week. And so I know that Dave Ressler was going to be looking into some of those, but I think that that deserves some introspection and some looking at it about what's going on there. Those are just a few of the items that I was hoping to talk about in the round robin. And thank you guys. What an informative meeting today.
Thank you, Tori. I know Karen's taken a list. And anyone else? If not, yeah, Greg?
I'll just make a quick comment.
Sure. Go ahead, Dave.
I very much appreciate names of individuals so that we can trace it down and try to identify where miscommunications are occurring and how we can tighten up those processes. I know we always have a lot of work we can do. It's a complex process, particularly on the weekends. A lot of what I hear about, and we have, challenges in general with communication. So I would love to hear names and specifics, and I'll trace them down and happy to call people and talk to them and learn more about how we can do better.
Briefly, I was just going to say, Marky, regarding the communication strategy, I'm not sure how broad that is and what it means, but I think that building public confidence boosting is something that we can focus on as well as part of that, just so, and I think we're getting there with these conversations, but it's something we could certainly plan on through work with outreach, and maybe that involves working with ACRA or working with a PR firm or our PIO or somebody, just so keep our messaging going, so we can build public confidence that we are paying attention to what's happening in the world of testing, and we're doing everything we've talked about today. I think that's important.
Thank you, Greg, for that comment. And with that said, do I have a motion to adjourn?
I'll move.
Thank you.
I'll second.
Thank you very much, Jeannie. All in support, raise your right hand. Thank you all, and thank you, staff, for all your hard work. A great meeting. And thank you, Kim,
all.
and thank you, Dave.
Thank you,
Thanks,
Marky.
everyone. Thanks.
Thank you for all the information. Thanks for all the hard work.